Kavita will be first.
He will be here.
Anyhow, inauguration time all should be there. We can keep the chairs close and try to be seen.
We'll start on time, yeah?
Yes.
Give a small piece of paper.
No, correct. You can give me that. Yeah.
This can be done. Yes. LCD paper. Electrical Novana, so that one of the from Sidhu.
Start பண்ணிடலாம் சொல்லிட்டாங்க. ஏதோ 37 பண்ணிட்டாங்க.
It's not so related to serial. This is in serial, no? This is your handwriting.
No.
She doesn't know.
Marty, start. Connect. You will speak. She will speak after inauguration.
Till the music is over, Kavita doesn't have work.
Kavita, come. Yeah.
And switch off the. I will have put it in silent.
I didn't. Very good morning, all of you. Am I audible?
Yes, sir, you are audible. Good morning,
Oh,
sir.
thank you.
Good
Thank
morning,
you.
sir.
Good morning. Very good morning. Very good morning. A very hearty and warm welcome, all of you, to this second webinar of SOP, which is organized by the headquarters of SOP, Department of Physiology, JIPMER, Puducherry. I extend a hearty welcome to all of you. I welcome our president, our past president, our vice presidents, all office bearers, and all the registered delegates for this webinar to this special event. And today because we'll be speaking a lot of things, I won't take more time to introduce. Straight we'll go to the program. We start with the lamp lighting. Before that, I hand over the mic to our comparer, Dr. Kavita.
Honorable delegates, respected participants, a very good morning to one and all. It is an immense pleasure to see you all here. I, Dr. Kavita, feel privileged to welcome you all on the behalf of organizing team for SOP International Webinar on Research in Clinical Physiology as a part of SOP International Webinar Series on Research and Publications in Physiology. This webinar is organized by Association of Physiologists of India, Department of Physiology, JIPMER, Puducherry, as a part of farewell ceremony as a mark of respect to our respected and beloved Dr. G.K. Pal sir, the General Secretary, who will be relieved from JIPMER.
You are there next week, na?
Executive Director of AIMS Partner shortly.
Next week, are you taking chutti?
I am delighted to welcome you all once again to this webinar.
Chutti hai ki nahi? Question is simple.
You can start now. Start the music. No, left.
When invocation descends into the heart, if there is darkness within, it illuminates it. And if there is already light, the invocation intensifies the light. Dear friends, a lighted lamp does not speak. It introduces itself through its life. Achievers never express themselves, but their achievements express. So to express this great achievement of organizing the international webinar on research in clinical physiology, I request Dr. G.K. Pal sir to light the digital lamp as a tribute of Mother Saraswati, the goddess of knowledge.
इसमें मैं म्यूट हूँ ना, यू अनम्यूट।
Thank you, sir. Prayer works wonder. Prayer should spring from the heart. Thinking of a supreme power beyond all human inadequacies is a kind of auto-suggestion. Over to Mother's organ music for a period of 1 minute.
Yeah, stop me, stop me, stop me. Yeah.
Without taking much of your time, we will start this virtual event shortly. I'm super excited to have you all here excited about all the amazing presentations that we are going to have today. Now, before we begin, let me remind you one thing. Please mute yourselves upon joining the webinar and put up your queries in the chat box, which will be taken up for question and answer discussion session later. Again, it's a pleasure to welcome you all. Let's begin with the scientific session today. It will be my honor to invite Dr. Rajesh Katere, sir, Associate Professor, It will be my honor to invite Dr. Rajesh Katere, sir, Associate Professor, Department of Physiology and Director, Division of Cardiovascular Physiology, School of Biomedical Sciences, University of Otago, New Zealand, for providing keynote address on molecular markers for early diagnosis of heart disease.
He is MBBS and directly PhD. University of
Sir
Ottawa.
is having 165 publications with 5,231 citations.
That's why he's a PhD. Dude, you'll get parking.
And sir, fields of interest includes molecular mechanisms involved in the development of cardiovascular complications in diabetes, role of microRNAs in cardiovascular diseases, development of novel genetic and stem cell therapies for treatment of ischemic and non-ischemic cardiovascular complications. We welcome you, sir.
We'll just cut away. Yes. Right, right. No. Yes. No. I'll make a phone call to him.
Sorry, can you hear me now? You are muted. I can't hear you.
Yes, good morning, Dr. Katari.
Oh, good morning, Professor Paul. I think I joined in. I was waiting on the wrong link. I can hear you all.
Yeah. Nice. Yeah, please go ahead. We have already introduced you. You can start now.
Yeah, I saw that. So I'm going to start sharing my screen. Can you see my screen?
Yeah, it is visible. It is visible.
Awesome. Okay. Thank you. Thank you very much. And thanks to Professor Paul for this kind invitation. So actually I'm not in Dunedin this week. So we have come for a family holiday in north of New Zealand. This is a city called Rotorua, where we have a lot of geothermal spas, natural spring water. So I just had water bath in the mornings. So just came from there. But because Professor Paul, I know Professor Paul very much, and this is respect to him as a farewell. So I thought maybe we should. I made my family to wait in the spa, so I have come here to present for you. So I won't take too much time. I'll stick to my time. So let me go straight into my presentation. So I'm going to talk today about, hopefully some of you might hear about me talking before about the research going on in our lab. So today I'm going to talk more about some of the clinical research which we are doing based on whatever we have been doing in the past few years. So I'm going to start with some of the statistics, what we see in New Zealand, like in several other countries. So in New Zealand, heart disease is biggest killer. And we know that every 1 in 3 deaths in New Zealand are caused by cardiovascular disease. And every 90 minutes, 1 New Zealander dies because of heart disease. And majority of the heart disease is caused because of diabetes. And it's been well established now that diabetes is an independent risk factor for cardiovascular disease. So if we look at the incidence of diabetes, it's a global pandemic now. So in 2040, which is another 18 years from now, we'll have almost 642 million people with diabetes. So every 1 in 3 individuals, or every 1 in 3 individuals, when we see in some other few more years, will be diabetic. So, and it's also very difficult to understand that, not to surprising that every 6 seconds a person dies because of diabetes. So diabetes is a global problem. So looking at the chronic complications in diabetes, there are several diseases starting from, it affects everywhere, pretty much everywhere in the body, starting from brain. And what we are interested is more in the heart. So my team is more interested in looking at how diabetes affects heart disease. So we know that 70% of people with diabetes die because of cardiac failure. And we also, not only cardiac failure, so we also know that 20% of diabetic patients develop some form of chronic foot ulcer. And this is particularly more prevalent when patients have peripheral artery disease. And if we don't treat them, 60% of them undergo amputation, they lose their leg. So it definitely affects the quality of life. And we also know that diabetes affects several cells within the heart, starting from the endothelial cells. It induces fibrosis. It can affect the stem cells, but also it can increase the cell death. So together, all these are called as termed as diabetic heart disease. So diabetic heart disease is a combination of diseases which is induced, cardiovascular diseases, which is induced in people with diabetes. So naturally, we see the patients at this time. So we diagnose the patient having diabetes, and then we either treat diabetes, or obviously the disease progresses. But what is interesting based on the research is that these individuals who are diagnosed as diabetes have been pre-diabetic, or starting from insulin resistance. They start developing insulin resistance at least 10 years before they become diabetic. So this is interesting because we don't see these patients, majority of these patients in the clinic, right? So we see them here, then of course we start treating the blood glucose level. So this actually tells us why, in spite of treating these patients very well, or in spite of treating diabetes well under control, why do we get such an increased microvascular and macrovascular complications? Or why do the heart diseases so much higher in diabetic people? That's because we are missing here. So we do not know what happens here. So what we have seen in the previous studies is that the disease can actually start much earlier before we actually see the patient. So we demonstrated this using an animal model of type 1 diabetes. So where when we looked at the cardiac function in these animals at different time points, we found that without having any coronary artery disease, these animals develop the symptoms, signs of cardiac failure, the disease progress. So this looks quite quick in the animals, but obviously the lifespan of animal is much. It's for example, lifespan of mouse is around 18 to 24 months. So looking at that, this is taking some time. So as the disease progresses, we know the pink line here shows the diabetic heart is having the deterioration of cardiac functions. And what we also did at that time is it's not coming. So we also collected samples at the early time point when these animals were completely normal. And when we looked at some molecular markers, we found that when the cardiac functions are completely normal, the molecular markers, there is already some molecular changes happening in these heart. So the echo doesn't detect anything, but at the cellular level, there's already some changes happening in these heart. So this suggests that early diagnosis is essential to treat the disease, at least in terms of diabetes. However, due to the absence of any specific symptoms, it's not easy to diagnose diabetic heart disease at early stage. So we need a specific and sensitive biomarkers to identify this early stage. So you probably heard a lot of, before, if you heard about me talking before, so you heard about this microRNAs. So microRNAs are those short, non-coding, single-stranded RNA molecules. So they are known to regulate the transcriptional and post-transcriptional gene expressions. And microRNAs have been demonstrated to play a critical role in modulating this physiological and pathological events. And most importantly, microRNAs are tissue specific. For example, the cardiac tissue has the specific microRNAs. The brain tissue has the specific microRNAs. The vascular tissue has the specific microRNAs. And we also know that dysregulation of microRNAs are pathological. In addition to this, we also know that these microRNAs, usually they are secreted, synthesized from nucleus, they mature in the cytoplasm, and they produce an effect within the cell by binding to the target genes. But interestingly, these microRNAs are also released out of circulation, either as microvesicles or exosomes bound by membranes, or they are released as naive microRNAs where they get bind to those the protein particles, most commonly HDL or GO proteins. So this characteristics of binding to something or being incorporated within those microvesicles. So these microRNAs remain stable in the circulation for a long time, because we know that even messenger RNAs are secreted out, but because of these, a lot of RNA is present, they are degraded straight away. And this doesn't happen in case of microRNA. So they remain stable. So what we did first is to understand whether is there any change happening in microRNAs in diabetic individuals. So we started recruiting participants. So far we have 132 volunteers being recruited in this study. So all of them are New Zealand European population. There were 50 diabetic and 82 non-diabetic individuals. So the diabetic participants are completely normal, at least from the history, apart from their being diabetic, and they have been well treated. The blood glucose level have been maintained very well. And what we collected blood samples from these individuals, and then because we know that microRNAs, we go back one slide, because we know those microRNAs are secreted into circulation, we isolated RNA from them, did a real-time PCR analysis to look at the microRNA expression level. So interestingly, what we saw here is, in spite of them being completely normal, having a normal lifestyle, the red dot shows here the diabetic changes in the microRNA expression in diabetic individuals. And as you could see, there's a number of microRNAs being dysregulated in these individuals, in spite they are being completely normal. So just to name them, we found some of the pro-angiogenic. These microRNAs play a essential role in developing angiogenesis or downregulated in diabetes. Some of the microRNAs playing the role in cell survival. So they reduce apoptotic cell death or downregulated. Also, the microRNAs associated with antifibrosis are downregulated. Interestingly, some of the microRNA, which is associated with aging of the cell, was upregulated in diabetes, including another microRNA here, 320 and 320. So this research suggests that microRNAs are definitely playing role in these some things happening in terms of microRNA within the diabetic heart. And we did follow up these individuals, and as you could see in this table here, there are we're looking at some of the cardiovascular disease events in those individuals, because at that time of recruitment, they're completely normal, no cardiovascular disease events. But as we could see, this should be non-diabetic. It's been wrongly labeled here. The red line is non-diabetic, the blue line is diabetic. And we could see the cardiovascular, some of the events have been increasing in diabetic individuals. Among 74 individuals, we found that 16 of them already developing some form of cardiovascular disease. And we were able to relate that to microRNA. So this suggests that changes in the microRNA could be a potential biomarker and much earlier in diabetic individuals. So based on this, we have published a number of papers using both mixture of clinical and preclinical studies looking at microRNAs and endothelial function, microRNAs associated with fibrosis, microRNAs associated with cell death, and even microRNAs associated with stem cells dysfunctions. So these are all very good. So we had a lot of preclinical data and also some of the clinical data, which was very helpful. But as a translational researcher, I always wanted to take these results into the clinic. So where from here? So that's where I started collaborating more with our clinicians here in Dunedin. So Professor Michael Williams and Sean Coffey. So Jaya was the researcher was working on this project. So we started understanding to see whether can microRNAs be used as a diagnostic and prognostic marker for ischemic heart disease. So why do we want to do this? Because again, going back to history, we know that patients with ischemic heart disease, once they develop a heart disease, they had to undergo regular frequent consultation with we had frequent follow-up visits to GP. So the best way to understand the cardiac function is by doing an echocardiography. But not everyone, at least in New Zealand, not everywhere we can do echocardiography. So therefore, we wanted to know whether we can we use microRNAs to understand whether they can be a diagnostic and prognostic biomarker. So we recruited newly diagnosed patients with ischemic heart disease. We assessed the cardiac function with echo, and then we collected the blood samples at the time of recruitment. And we followed up these individuals every 6 months for up to 5 years. So far, we have completed 4 years in our study. So the question here is, can changes in microRNA reflect the changes in cardiac function? So we chose 4 microRNAs for this study. So microRNA 1 is a cardiomyocyte specific microRNA. Its downregulation is associated with dysfunction in cardiac conduction. MicroRNA 126 and 132 are endothelial specific microRNA. They're associated with ischemic heart disease. And microRNA 34A is a cardiomyocyte specific microRNA. Again, they are associated with pro-aging. If you remember, these microRNAs were down and up in the diabetic individuals. So we had 53 participants in the study, 44 male and 9 female. Not much difference in age, not much difference in the baseline cardiac function. Looking at the development of, looking at the ejection fraction or the cardiac function in those individuals at every 6 months or 6 months and 1 year time point. So At 60 months, we don't have much samples. We have half of the samples because the study is still ongoing. But what we could see is there's not much change happening in terms of ejection fraction. But looking at this EE dash, and we know it's a marker of diastolic dysfunction, is significantly increased, which means there is a development of diastolic dysfunction in these individuals. And looking at the microRNAs, it was up and down there. So initially we saw this microRNA 1, 126 and 1 and 126. They were good microRNAs, just keeping it simple. There was a small increase in these microRNAs at 6 months, although not significant at this time point, suggesting that heart is doing something to compensate to release these microRNAs more so that they can compensate, overcome the injury. But importantly, as the disease progresses, we can see that both microRNA 1, 126, and 132 are all downregulated in these individuals. Interestingly, we did not find any such change in 34. This is a bad microRNA. This is a microRNA, pro-aging microRNA. We didn't see any change here in the initial stage, but later on here we see that there is a small increase in 34A, although it's going down at 60 months. But as I said, there's still a lot of samples to come in at 60 months, so we can't really say anything on this. We then looked at the correlation between some of the good microRNAs and diastolic function, so EE dash, which shows that there is a negative correlation between EE dash and microRNA 1 and 126, suggesting that the microRNA 1, the changes in microRNA 1 and 126 can't reflect what's happening in diastolic function. And we also found some positive correlation between good microRNAs, 126, 1 and 132, 126 and 132, suggesting that these microRNAs are working together, compensating each other. So this phase 1 study suggests that early changes in microRNA can predict cardiac function. I just want to finish off by showing some couple of, one more interesting study where, because there's a COVID season, so obviously we are interested in microRNA. So we wanted to know whether can we use microRNA as a biomarker for COVID case or something with the COVID. So in our previous study, this was published last year. The reason why we started this study is because obesity is a risk factor for COVID. And we know that prevalence of obese individuals admitted with COVID-19 ranges from 30 to 60%. And once infected, obese individuals have developed a serious illness associated with higher mortality rate. But exact molecular mechanisms still remain elusive. And in the previous study, we showed there was a obese individual showed increased expression of microRNA 200C. So microRNA 200C is a direct target of ACE inhibitor, ACE2. So ACE something might strike your bell because ACE is the receptor protein for ACE2 is the target proteins for the COVID spike protein. And interestingly, we found that microRNA 200C was negatively correlated with ACE2. We found there was an increased expression of microRNA 200C in obese individuals, and this was associated with significant decrease in ACE2 in obese individuals. And the correlation also showed a negative correlation between microRNA 200C and ACE2 in obese individuals. So while we can say that ACE is actually the spike protein, so if you reduce ACE2, we can think that yes, COVID cannot enter our lung. That's actually not true, because the previous studies have shown that ACE2 also has a protective role, because they did a study where they had patients with the cardiovascular disease having lower ACE2 and patients with higher ACE2. When they're exposed to COVID, the patients with lower ACE2 had a higher incidence of disease. So the severity, there might be lower incidence of disease, but the severity was much higher because ACE2, although it stops, if you reduce ACE2, it can reduce bringing in COVID into your lung, but the COVID spike proteins are so strong, so they bind to whatever ACE2 is available they use everything, which means ACE2 cannot produce its anti-inflammatory effect because ACE2 is a known anti-inflammatory agent. So reduced ACE2 is not actually a good thing for COVID in obese individuals. They may have lower incidence of disease, but the severity is going to be high. So the early detection of microRNA 200C in obese subjects may be significantly aid in mitigating the risk of contracting COVID-19, although it's no more very much valid now. So just to finish off, sorry, I hope I was in time. So we know that microRNAs are dysregulated in diabetic heart, and microRNAs are the earliest molecules to be dysregulated and have a pathological role. And we have shown in the past that in vitro and in vivo therapeutic modulation of microRNA can be beneficial to treat the disease. So usually they require a clinical trial, but we started our clinical trials now. We have done few clinical trials and several clinical trials are ongoing. I can't show everything because of time constraint. So most of them suggest that microRNAs are reliable diagnostic and prognostic markers of heart disease, and maybe COVID as well. But again, more trials are required. So I'll finish off by thanking our team and all my collaborators, without whom we wouldn't be able to do this study, and all our supporters. And again, once again, thanks to Professor Paul for inviting me to this session. He's a great friend of me, not only as a researcher, but also as a human being. So we always, we always communicate well with each other. And congratulations to Professor Paul for his new promotion. I don't know how do you say promotion, and I'm sure we'll keep in touch again. Thank you very much. And if there is time, I'm happy to take questions.
Thank you, Professor Katare, for a brilliant presentation from your excellent works.
Can't
And
hear you.
You presented all your latest works. I'm really delighted to see this. We don't have the question answer now. The question answer will be at the end, but you need not be there. You can go ahead with your program. Yeah, sure. Thank you so much.
Thank you very much, sir, for giving valuable insight on molecular markers for early diagnosis of heart failure. Thank you very much, sir.
Sorry, I can, sorry, can you, sorry, I was in mute, I guess. Can you hear me now?
Oh, yeah, you're audible.
Okay. Yeah, I can hear you now. For some reason, I didn't hear you before.
Okay, no problem. No, your program is over. You can go ahead with your personal
thank you very much.
program.
No questions for me?
No. Yeah, you can join your family for your the the celebrations. You can go ahead.
Sure. Thank you very much. And I'll keep in contact with you, Professor Paul.
Sure. Okay,
thank you, everyone. And have a good day. Cheers.
Yeah, thank you.
Thank you very much, sir.
No problem. Thank you.
Next will be on autonomic neurophysiology, vast scope for clinical research and investigation, which will be shared by Dr. Prabhati Pal ma'am, Dr. Vilkumari ma'am, and Dr. Dhanlakshmi ma'am. Now, it's my pleasure to invite Dr. Prabhati Pal ma'am, Professor, Level 15, Department of Physiology, JIPMA, Puducherry, as a speaker for this topic on baroreceptor sensitivity as a part of this session. Ma'am has published 120 research papers in national and international journals, having a Google Scholar citation of 1,614 and H index of 24 and I-10 index of 42. Ma'am is also a recipient of Vaithalingam Venkata Subba Reddy Medal for distinction for her performance in MD examination from Pondicherry University, Dr. N. Padmanabhan Memorial Award from Indian Association of Biomedical Scientists in 1998 for best research work in physiology, the KP Putraya Award for Best Teacher in Physiology, and A.V. Tilak Parvati Devi Award for Best Research Work. We welcome you, ma'am.
Very good morning to all of you. First of all, I thank Dr. G.K. Pal for giving me this opportunity to share on my thoughts on BRS. And my sincere and hearty congratulations to Pal sir for being appointed Chief Executive Director, AIIMS Patna. So this is a brief overview on BRS, the scope for clinical research and
ನೀನ್ ಲಾಗಿನ್
investigation.
ಆಗಿಲ್ಲ ನಿಮ್ಮ ಹೆಸರು ನೋಡ್ದೆ ಅದಕ್ಕೆ ಅಷ್ಟೇ ಮಾಡಿದ್ದೀನಿ ನಾನು ಪಾಕೆಟ್ ಅಲ್ಲಿ
Every time we do this. Yeah, go back, come back.
So bioreflex is an important determinant of the neural regulation of the cardiovascular system. The arterial bioreflex exerts a pervasive influence throughout the body. The receptors are carotid and aortic bioreceptors. The afferent vagal and glossopharyngeal pathways convey burst-like information regarding every blood pressure pulsation to the brainstem. The efferent pathways carry both blood pressure as well as heartbeat-related nerve traffic. The parasympathetic, that is the limb of reflex, transports burst-like patterns, whereas the sympathetic limb shows inhibitory response upon its BP pulsation. The heart is constantly under combined parasympathetic and sympathetic influence. The bioreflex elicits a reciprocal response of autonomic nervous system. When the BP increases, the afferent bioreflex nerve traffic intensifies, and the sympathetic traffic decreases, whereas the parasympathetic traffic increases. So it shows a reciprocal type of response. Moreover, the sympathetic outflow to the whole body is modulated by the bioreflex, thus constantly adjusting the vascular resistance. By adjusting systemic vascular resistance, the arterial bioreflex buffers blood pressure. So when blood pressure rises or falls, a few seconds are needed to accomplish the counteracting resistance adjustments. Means when BP rises, bioreflex takes it to lower the BP, and when it falls, it tends to help in rising the BP. Thus, the effects of the bioreflex on the heart rate are particularly relevant. For example, in stressful conditions, when the blood pressure increases, the bioreflex reduces the sympathetic outflow and increases the parasympathetic tone, which decreases the heart rate, thus protects the heart, which is useful against arrhythmias. Thus, both BP buffering and cardioprotection are major effects of the arterial bioreflex. Coming to bioreflex sensitivity, it can be defined as the measure in which the bioreflex vigor is expressed. BRS is defined as the change in interbeat interval in minutes for unit change in blood pressure. For example, when the blood pressure rises by 10 millimeter of mercury and interbeat interval increases by 100 millisecond, bioreflex sensitivity would be 100 by 10, that is 10 milliseconds per millimeter of mercury. This is a very beautiful article by Swen, published in 2013, about bioreflex sensitivity, its mechanisms and measurement. Coming to physiological perspectives of bioreflex, bioreflex responses mediated by vagal and sympathetic efferents exhibit significant difference in the time of onset of their action and the time delay in execution of effects. So, following an immediate and considerable rise in arterial pressure, the parasympathetic activation occurs faster, between 200 to 600 millisecond, whereas the sympathetic stimulation occurs after a gap of 2 to 3 seconds, and the peak effect of responses reaches more slowly. So as you know, the heart rate, that is the cardiac cycle duration, is around 0.8 seconds. So the modulation by sympathetic, when the next bit comes, the sympathetic modulation might not have started, whereas the parasympathetic modulation is quick. That's why the bioreflex sensitivity or bioreflex response is mostly a vagal action rather than a sympathetic axon. Moreover, the sympathetic mediated alteration in venous return takes much more longer time. Therefore, we can say the potency of bioreflex to control heart rate and BP on a beat-to-beat basis is mediated principally through the vagal activity rather than through sympathetic activity. The bioreflex modulation of heart rate is also greatly influenced by respiration, which we know as sinus arrhythmia. Inspiration decreases baroreceptor stimulation of vagal efferents, and expiration increases vagal activity by stimulation of vagal motor neurons. This is called the respiratory gate of vagal activity. Within the physiological limit of blood pressure, the baroreceptors constantly exert inhibitory effects on sympathetic efferent activity, which we study by various different breathing exercises and yoga. Also, many neural, humoral, behavioral, and environmental factors influence the functioning of the baroreceptor reflex. The cardiovascular diseases are usually associated with the impairment of bioreflex activity and associated with imbalance in sympathovagal outflow from the central nervous system to heart and blood vessels, resulting in persistent sympathetic activation. Thus, chronic bioreflex mediated sympathetic activation contributes to progression of the underlying disease process and promotes end organ damage. And blunted bioreflex gain is reported to be predictive of increased cardiovascular risk. The assessment of BRS was done by injecting a vasoconstrictive agent like phenylephrine, and reflexly decreases heart rate and interbeat interval. Soon after, it is being done by the latest instrument called Phenopress, which in Phenopress, the changes in blood pressure is, and its translation into HRV is measured, and the respiration related BP changes result in corresponding changes in parasympathetic and sympathetic outflow. The respiration doesn't only induce HRV but mediates the arterial bioreflex responses. Thus, this is a picture of showing how the bioreflex is being recorded. This is the graph, how you get the bioreflex measurement from Phenopress instrument. And this is one beautiful article which in detail describes the bioreflex sensitivity, measurement, and clinical implications. The normal values are taken as 20 to 40 millisecond per millimeter of mercury. Values between 14 to 19 are seen in pre-hypertension and pre-diabetes. Values of 13 or less are considered as a significant cardiovascular risk. The level of systolic blood pressure is an important determinant of bioreflex sensitivity. Bioreflex sensitivity has been linked with disease activity and severity of cardiovascular disease and metabolic disorders, and decreased bioreflex less than 12 is a cardiovascular risk. It has also been correlated with several altered conditions. It depicts both the limbs of autonomic nervous system, and it also, low BRS also indicates severity of autonomic dysfunction. It predicts risk of future cardiovascular events and denotes the state of cardiovascular morbidity. BRS is a beta marker of recovery from ischemic events and acute myocardial infarction. And BRS data should be carefully interpreted with other autonomic function test data and clinical findings. These are our publications. So to summarize, BRS is a good indicator of state of cardiovascular health of the subject. It is an excellent marker of CV risk assessment in health and disease, a good investigation tool for risk stratification, and is an indicator of prognosis of a CV event, especially heart failure, and ideal non-invasive research tool in cardiovascular research. However, in future, highly relevant investigations in the clinical setting and which is applicable to wide population for assessment of CV health status should be taken up for bioreflex measures. And BRS will be used in the CV risk stratification in many metabolic and non-metabolic disorders. The onus is on the physiologist to standardize and establish the clinical and research utility of BRS. This is our BRS team at JIPMER. Thank you.
Exactly.
Thank you very much, ma'am, for sharing your deep knowledge with us about BRS and its scope for research and investigation. Now, it will be my pleasure to invite Dr. S. Velkumari, ma'am, Professor at Department of Physiology, JIPMER, Puducherry, as a speaker for this session on heart rate variability. Ma'am has 26 research publications in various journals. She is also a recipient of Dr. Atratan Nanda Memorial Award from Association of Physiologists of India in 2015 for best research work in respiratory physiology. Her field of interest includes cardiovascular physiology, nutrition, and yoga. We welcome you, ma'am.
Thank you. Very good morning to you all.
Remove your mask. Remove your mask. This is something else.
Next. Very good morning to you all. Today I'll be talking briefly about what are the research done in heart rate variability. All of us know that is one of the extensively studied procedure. So I'll be touching upon the recent thing, and that too in COVID era, what is its role of heart rate variability. Before that, I'll just touch upon the basic physiological perspectives of heart rate variability. All of us know that heart rate variability is the variation in the instantaneous heart rate or the RR interval. Just go to the first slide. And no, next first one. So it is a beat to beat variation in either the instantaneous heart rate or the duration of the RR interval has become one of the clinical assessment tool. These variations are largely due to the respiration. That is why the main contributor for the heart rate variability is the respiratory sinus arrhythmia. And of course, other factors will also influence this. HRV reflects basically the cardiac autonomic modulations. Reduced HRV is associated with poor prognosis for wide range of clinical conditions. Conversely, a robust periodic changes in the HRV or RR interval are often taken as a mark of health. So next, when you see the application, if you see the application of clinical application of HRV, widespread, it is widely done tool, because this HRV measurement is based on the fact that they are non-invasive, easy to perform, and reproducible if you carried out under standardized condition. The most frequent application of heart rate variability is connected to the cardiological issues, and mainly the monitoring of post-myocardial infarction patient for this fatal arrhythmias and for the prediction of sudden cardiac death. What is established is HRV is used as a prognostic, predictive marker, and risk stratifier in myocardial infarction. Basically, these landmark studies like ATRAMI and other studies have documented this. Then if you see the methods of recording, although you can record this, record the heart rate variability for any number of any length of ECG, but what task force is recommended that short short-term HRV recording, minimum 5 minutes, or long-term recording for 24 hours. It has its own advantages and disadvantages. Short-term HRV recording is widely done to quantify the resting autonomic nervous system tone, that is the sympathetic and parasympathetic tone, whereas 24-hour HRV recordings is the gold standard of clinical HRV assessment because it provides greater predictive power than the short-term, because many factors influence this. That is why it is a more predictive value than the short-term HRV. And all this basically what we record is we record for a ECG, we amplify the signal, digitize, and then offline analysis will be done using a software. Here we use QBO software to quantify the ECG, signals. So this quantification of HRV is done by 3 important means. One is the time domain measures, where we use the statistical tools are applied to measure this time domain measures, and frequency domain measures, we use the frequencies are measured using the fast Fourier transform, commonly used as fast Fourier transform method. And the nonlinear measures are also widely used in clinical practice. That all of us know this, what is the time domain indices of this thing, which basically all this means the mean heart rate, RMSSD, SDNN, NN50, PNN50, all these things indicates the vagal modulation on heart. Then secondly, coming to the frequency domain indices, the total power, these frequencies, they're very low power frequency, LF, HF, all this LF, HF ratio, all these things. Hello, all this total power indicates the overall autonomic activity, and LF predominantly indicates sympathetic, although it represents sympathetic and parasympathetic. Whereas very low power has a more advantage with long ECG recordings, which indicates thermoregulatory and input from chemoreceptors, and thermoreceptor and renin-angiotensin, all of us know, and HF is predominantly indicates the parasympathetic, and LF-HF ratio, this indicates the sympathovagal balance. Coming to the point where the non-linear methods of measuring HRV, we use Pointcare Plot, which is a scatter plot in which each RR interval is plotted against. I'm showing a diagram, you can have a look on that. Each RR interval is plotted against the next RR interval as a point. It appears as an elongated cloud of point oriented along the identity of 45%, this axis. So here we quantify 3 important things. One is the SD1, which is the points, dispersion of points perpendicular to the line of identity. You can appreciate the line of identity, which predominantly indicates the BRS and the vagal, the HF of frequency, that is vagal drive. SD2 indicates the sympathetic drive, and S indicates the area of the ellipse, that is total HRV, and SD1, SD2 indicates the sympathovagal balance. This is what we get when we do this thing. When you do when RR tachogram you get, and then time domain analysis and frequency domain parameters are depicted here. All of us would have done this, most of us at least. So then all of you know the task force, the range for normal values given by the task force, the ranges, that is the total power, LF, HF and LF-HF ratio. But later on, the normative data for short-term HRV is published after task force report were reviewed by Noon et al. This study takes the normative data from 44 short-term HRV studies, normal studies involving 21,430 adults, and they have given a different range of our population. Then there are various, you can, because of time constraint, I have not read that. You can go to that paper and see that. There are various factors which affects the heart rate variability. One is non-modifiable factors like age, gender, then modifiable genetic factors, then modifiable factors which include smoking, caffeine, posture, physical activity, the respiratory activity, the respiratory sinus arrhythmia, main principal activity, then blood pressure changes, then arterial baroreflex, humoral changes, and certain pharmacological drugs also, which known to affect this heart rate variability. With this brief introduction, now we'll go on to what is done in the research. See, HRV is widely done investigation for all cardiac. It is widely done in most of the cardiac and non-cardiac illness. And individuals, HRV is a physiological marker of cardiac autonomic modulation. Them much before the onset of clinical symptoms of disease, alterations are known to occur in heart rate variability. Lower heart rate, scientific evidence has well documented that lower heart rate variability is associated with higher risk of all-cause mortality and also cardiovascular events in patients with CVD. Then the other thing is the importance of 24-hour recording SDN, specifically the time domain indice, SDNN is the gold standard for medical stratification of cardiac risk. They say that SDNN value below 50 millisecond is indicates that unhealthy heart, and 50 to 100 millisecond is compromised health, and one should have above 100 millisecond for a health, which indicates health. And then next. The thing is the lower parasympathetic activity. So, and further, the lower parasympathetic activity, which is characterized by decrease in the HF and increase in the LF, which is an indicator marker of cardiac sympathetic drive, along with elevated LF-HF ratio is documented as a CVD risk. Any factor which affects the autonomic nervous system will invariably influence the heart rate variability. So there are n number of physical, mental conditions is known to affect. So people have done extensively the heart rate variability in all these conditions, like in various endocrinological things, autonomic neuropathies, thyroid dysfunction, cardiovascular disease, renal disease, neurological disorders, and certain mental conditions like depression, post-traumatic stress disorder, anxiety, stress due to traumatic stress, or stress due to any cause. All these things, the autonomic nervous system is affected. Therefore, there is a change. There is change observed in the heart rate variability, and so they are more prone for the cardiovascular disease risk. So what is so now in this COVID era, what I wanted to know is, when I searched the PubMed in this thing, there are a lot of work done on cardiac and non-cardiac illness in other conditions. But in COVID-19, they have recently I've seen this article, which is published in 2021, higher HRV. They have done heart rate variability in COVID patients. Higher HRV predicts greater chances of survival, especially in elderly, and independent of major prognostic and factors. Lower HRV predicts ICU indication and admission in the first week hospitalization. This is one of the important aspect of HRV, and there are no much of Indian papers which is seen in HRV in COVID, this thing, because all of us know the acute complication, but long-term complication of COVID is not known. So it is one scope where you can take up and do this thing in Indian population. And then there's another recent study in April 2022, it is published. They have analyzed the effect of all abroad studies to analyze the effect of post-COVID on HRV indices. They have done 24 hours HRV monitoring, Holter recording, that is in during the post-COVID period, that is 12 to 26 weeks following the diagnosis of COVID-19. This study revealed that parasympathetic activity and increased HRV in patients with history of COVID-19. So therefore, the survival is better. So, so there are various methods by which you can improve your heart rate variability, which is well documented. The physical exercise, mind-body training like yoga, meditation, and HRV biofeedback training. Since I was asked to talk on this thing, the research part, what I wanted to give in the take-home message is that it is extensively done in many of the conditions. But in COVID, one area we can now explore on. And HRV is a non-invasive and objective tool, measure the cardiac autonomic tone. Decreased heart rate variability is definitely linked to adverse cardiac events. Optimal, see, high HRV is also not good. Optimal HRV is a marker of good health, self-regulatory capacity, and also the adaptability or resilience. With these few words, I thank you. Thank you.
Good, very good. Okay. 11 minutes. Nice. Yeah. How are you not able to unmute? Sorry, mute.
Thank you very much, ma'am, for sharing your knowledge about heart rate variability.
Go ahead, you speak.
Now it's my immense pleasure to invite Dr. Y. Dhanalakshmi ma'am, Additional Professor, Department of Physiology, JIPMA, Puducherry, as a speaker for this session on cardiovascular autonomic function tests. Ma'am is having 14 years in undergraduate and 11 years of postgraduate teaching and research. She has few publications in her credit, published in national and international journals. And her field of interest includes cardiovascular physiology, neurocognitive physiology, and yoga therapy. We welcome you, ma'am.
Every time it is coming, this can be closed now. Yeah.
A very good morning to one and all. At the outset, I'd like to congratulate our General Secretary SOP, Sir, Senior Professor, Physiology, and on his newer higher achievement, and our heartfelt thanks and gratitude for all the opportunities till date. And today, my session will be on cardiac autonomic reflexes. So getting it straight into the topic proper, the cardiac autonomic reflexes, earlier known as TESS. So they are heart rate and BP response to standing, DBD, that is deep breathing difference, Valsalva ratio, IHG, that is isometric hand grip, and cold pressor tests. All these components test the integrity of the autonomic nervous system, as my previous seniors have already praised about it. Because of the paucity of time, I'm going to straightly touch upon DBD and IHG. I think that would make a better relevance to the present date scenario on the disease state, that is the pandemic there, and why at all we need a cardiac autonomic function tests. First and foremost, well-known reason is the coronary artery disease. Then the second entity, of late, very many news we are listening to or hearing, not only because of the pandemic, but because of also recent, the people getting into sports activities or any other physical exercise or such, they they experience sudden cardiac death. We have seen that recently. And then familial dysautonomia. And an important entity which we get to know in the recent papers is that these CAFTs, especially the IHG as well as DBD, they have a major role in immune modulation. So what are all the methods of determination of these components? That is, we go in for a baseline ECG recording, and most importantly, to be even more robust, 24 hours hold a recording of the ECG and estimation of BRS, which Madam has already touched upon. And amongst this, most important benefit amongst the cardiovascular reflexes estimating maneuvers is they are proactive maneuvers. They are cardiovascular reflex tests, again, I like to say. And the most important component is they can be performed bedside. And the reference to that is easily understood there. So then what are all the components of the reflex arc? I think we are already aware of that. So then all requires...
Just move. Yeah, may I request all our participants to mute themselves? Please mute. Robin. Yeah, correct.
To continue, amongst this component, I'd like to say the lab standardization variables, especially the confounding ones. Stimulus standardization is very, very, very important because they are all greater influences on the outcomes. And they are especially referred to as arterial and cardiopulmonary baroreceptor reflexes. Next slide. Yeah, then getting into the test proper, that is debriding tests. So it mentions about it, it talks about the heart rate response to debreathing, which is a reliable indicator and a sensitive measure of the cardiovagal function. So what is the principle involved? Usually they say normally or under steady state conditions, inspiration increases the heart rate and expiration decreases the heart rate, which is referred to as respiratory sinus arrhythmia. And basically it is supposed to be predominantly mediated by the vagal tone or the parasympathetic innervations of the heart. And what are the mechanisms of sinus arrhythmia? We get into the nuances proper. There is alteration in autonomic activity. There is activation of the vein bridge reflex. I think most of us would be aware of this. And there is irradiation from the inspiratory center and activation of the atrial stretch reflex. So all these components are very important in DBD, the measurement components. I think this is all the lab standard, which is rampantly followed everywhere in every other organization. And the protocol, definitely the subject should be properly instructed to perform 6 breaths per minute. And he should breathe in a continuous way, be relaxed, and should be in a sitting posture. And if these are not maintained or done properly, the test is to be repeated. So this is what recording for a period of 30 seconds, the baseline ECG, and the maneuver obtained, ECG recorded during the maneuver, baseline ECG recorded after the maneuver for 20 seconds, and blood pressure is taken immediately. Then followed by blood pressure recording after 5 minutes. So this is the recording that we are supposed to get, and a tachogram from the responses or the recordings is made and it's obtained, and it is obtained during debreathing, from which we obtain the expiratory-inspiratory ratio. Here we have the mean of the values mentioned there. And then these are all the normal values, of which I'd like to say that you have a look at age 21 to 25, it's almost more than 1.2. And another common entity which you have observed, 46 to 50, it generally seems to gradually decrease more. I mean, it should be more than 1.11. And when you see the debreathing difference, 41 to 50, it should be more than 16 beats per minute. I think it is understandable, and each lab should have a standardized value. So what could be the abnormal responses when commonly we record? That is, we have a common entity here, multi-system atrophy, progressive autonomic failure, and the most well-known full-blown entity, diabetes mellitus, and autonomic neuropathy, presenting in varied components. So what are the factors which could affect the debreathing technique? As we age, EI ratio decreases, EI ratio decreases, and definitely posture has an influence in this recording. So the best results would be obtained. I mean, at your take, is supine posture is at its maximal, right? And all these components, all these drugs are to be better avoided. What is the application, main, application of this test? So it is assessment to reinstate of the parasympathetic function on the heart in response to deep breathing. So both cardiac vagal inhibition and activation are tested in this entity. So please understand, and the very important entity here, loss of normal respiratory sinus arrhythmia is a very early sign of autonomic neuropathy in diabetes mellitus. So that gives a high for this test. So definitely, as others have said, it has a prognostic value in patients susceptible to sudden cardiac death. The other entity is IHG, and the apparatus, we all know that's a hand grip dynamometer, and the output is the blood pressure unit. So this entity is used to assess sympathetic function of the heart. So a sustained hand grip against resistance is tested, which tends to increase the heart rate and blood pressure. So then what is the basis? What is the physiological basis? Metabolites tend to, especially during any performance, they increase, and which are detected by the light sensitive nerve endings within the skeletal muscle interstitium. And there is also observation of discharge of group 4 metaboreceptor. That is, they are the afferent fibers, type 4 afferent fibers, which increase the sympathetic nerve activity. And we know what is the outcome following sympathetic nerve activity increase. So this is one of the postulated mechanisms following effect of exercise, which is immediate effect of exercise. And that was also explained by Mostofi M. S. et al. That following regular exercise training, a decrease in blood pressure is seen after 10 weeks. Please understand that this can be used to reduce the effects of hypertension. So other than the standard medications or whatever it is, a regular follow-up, this is an isometric exercise component. So this, when followed meticulously, so it can, over a period of time, that is a longer period of time, can reduce the blood pressure. So how does it happen? It increases the capillary density, increases mitochondrial density, there's activation of the oxidative enzymes, and there is increased oxygen extraction in the skeletal muscle. So other than those mechanisms, in the trained muscle, there is increased utilization of the aerobics there. And as a result, there is decrease in the concentration of the metabolites because of the long-term training, and causes less stimulation of the metaboreceptors, which causes a decreased sympathetic response, ultimately leading to decrease in the blood pressure. So these authors and references prove the same. Also, they say that exercise improves local endothelial dependent vasodilatation in the hypertensives, especially on treatment. So then there is also another reference article which presents about the chemoreceptor reflex responsible for sympathetic nerve activity, which is reduced by decreasing the sympathetic nerve traffic or response, leading to a decrease in blood pressure. Here, the stimulus afferent efferent is well known, and the methodology, I think I'll cut short because it's well-known entity, but here, what is the interpretation here? Increase, especially for the diastolic blood pressure component, we need to see that it should be more than 16 millimeters, which is accepted to be normal. So anything between 11 and 15 is supposed, millimeters of mercury is supposed to be a borderline alteration, and less than 10 is supposed to be abnormal. So voluntary muscle activity is associated with sympathetic outflow to the muscular system, which increases the heart rate and blood pressure. So the rise in heart rate Please understand the rise in heart rate is also due to parasympathetic withdrawal. So it can be stated in other terms. And these cardiovascular responses to this type of exercise, which is isometric exercise, are also mediated partly by the metabolic and mechanical changes or both in response to contraction of muscles. Research past and present, hand grip studies. There's a study by Rinku Garg et al. And in 2014, which says a longer time period of, IHG, which is executed at least for a period of 3 times per week for 10 weeks gives a better result. It only there is a reduction in the diastolic blood pressure. Here, both systolic and diastolic are reduced very significantly. So you could observe the response as observed in the bar chart. Very good reduction is that these are all the mean values at rest and after 10 weeks of response. There are other authors who have supported this entity, Miller et al. And Debriding et al. Other studies, people also used, actually they grouped pre-hypertensive subjects into 3 groups and put these exercises. There's especially IHG for a period of 24 days, the first group. The second group, again, another round of 24 days, group 2, and group 3, again, another 24 days. But the intensity of the exercise was around 50% of the MVC. What were their observations? So this is a very, very important, lead here by International Journal of Physiology, Pathophysiology and Pharmacology, published in February 2022, where there is improvement in the CD4 cells and CD4 and CD8 ratio. So to state that here the increase in duration produced a more change rather than the intensity of the exercises. So there are other studies also. There are meta-analysis studies which say that slow, deep breathing was associated with significantly lower pain scores. And there were studies conducted in individuals who had undergone, operative interventions, and those people who were assessed by their psychological outcomes. RCTs were performed, and they all showed that their pain scores decreased. They were all the RCTs. So the postulated mechanism involves the baroreceptor reflex, which is stated to influence hypoalgesia by inducing respiratory changes. That's it. So this is another important reference was from Nuzinovich group, where familial dysautonomia, where this entity was studied, where the delta EI and the EI ratio, where DBT served as a reliable method to quantify autonomic dysfunctions patient population. And you could very well see in the first graph, in a normal individual, how is the response, and in individuals with familial dysautonomia, how there is a grossly vast reduction in the DBT responses. So these are all the references, newer references from the past and the present with regards to IHG and DBT. Thanks for the opportunity. Thank you. Thank you, sir.
Thank you very much, ma'am, for sharing your knowledge about cardiac autonomic function tests.
Yeah.
Now, it will be my privilege to invite Dr. Latika Mohan, Professor and Head, Department of Physiology, AIIMS Rishikesh, Uttarakhand, as a speaker for next session on high altitude physiology and medicine, an emerging branch for clinical research. Ma'am is having 33 years of teaching experience, several research publications in national and international peer-reviewed indexed journals, and have delivered several oral presentations and guest lectures in various national and international forums. Ma'am is also life member of Association of Physiologists and Pharmacologists of India, Physiological Society of India, Association of Physiologists of India, and Academy of Physiology. And she also holds yearly membership for International Society for Mountain Medicine and American Physiological Society. Her field of interest includes clinical physiology, neurophysiology, medical education, high altitude, underwater, and environmental physiology. She is also Vice President of North Zone, Association of Physiologists of India, President Indian Society for Hypoxia and Mountain Medicine, and Board of Governors School of Health, Indira Gandhi National Open University, and expert for LSRB, Physiology of Extreme Environment and Behavioral Sciences. We welcome you, ma'am.
Good morning, Professor Latika Mohan.
Good morning to you. Good morning.
Yeah, most welcome, and please go ahead with your presentation.
Thank you. I'll just share my screen. So you can see my slide, the first slide?
Yeah, it is visible, madam. It is visible.
Oh, fine. So at the outset, I am extremely honored to be part of this international webinar, which I was told is to bid farewell to Dr. Pal from JIPMER, but I view it like a celebration, an academic celebration for his latest achievement, and I feel hope for the country and for education that he is at the helm of affairs at AIIMS Patna. So I have tried to make a brief presentation to try and inspire more young people to come towards this exciting field of high altitude physiology and medicine. And I hope they can see how much they can contribute and more people can come towards it. That is my
Madam, can you put it in the PowerPoint presentation mode?
Yeah, of course.
Yeah, yes. Slideshow.
Yeah.
Slides share.
Yeah.
Yes, it has come.
Yeah. So my association with the high altitude physiology and medicine research started in 2004. I was posted in Ladakh in a high altitude research center, where I did several projects along with DRDO and with IGIB and others. So this photograph of me here in this monkey cap is with one of the team members of Dr. Pasha of IGIB in Khardungla, which is at 18,000 feet above sea level. So, and I took my children there also. So it was, this is how I was exposed to it, and I could, get into this very exciting field. So just to briefly bring back, bring everyone up to the same listing. The latest definition of high altitude has been modified slightly from what we teach in undergraduate physiology. And we now classify altitude as moderate, high, and extreme altitude. Moderate altitude is between 1,500 to 2,700 meters, which would be the altitude of our comfortable hill stations where we all like to travel and go on holidays and so forth. High altitude is defined as more than 2,700 meters, where we are traveling for most of our places of pilgrimage like Kedarnath, Badrinath, Hemkund, Amarnath. These are all located above this 2,700 meters or 9,000 feet. And extreme altitude is where it is more than 5,500 meters. That is passes like Khardungla and Pin Parbat, where people generally go for treks or that kind of tourism. And there's Sri Dongwa Lake, which is there in a very famous lake, spiritual lake, which is there in Sikkim, where people, many tourists like to travel. So this is just to, now what gives us this definition of altitude? What is the reason why we have these levels defined? So there is a definite physiological response which is going towards acclimatization or adjusting the normal physiology to this stressful or different kind of atmosphere. Now, if you remember from the previous slide, even moderate altitude, that is between 1,500 to 2,700 meters, that is in Shimla, and this process starts. So even Mussoorie, Shimla, when you are traveling, and if you have some kind of pre-existing disease also, it may have its various effects. there is decrease in exercise capacity, and you have an increased risk of one of the known high altitude diseases that may be acute mountain sickness, high altitude cerebral edema, high altitude pulmonary edema, or chronic mountain sickness. So it starts above 1500 meters and it can go further. It becomes more likely to happen as you go higher and higher into altitude. Above 5,500 meters, which is extreme altitude, acclimatization does not occur. I mean, there is up to a limit acclimatization occur, but nobody completely acclimatizes to that altitude. And in Siachen, where our soldiers are, is also above that altitude. So what are the environmental challenges at high altitude? Each of this is an opportunity for research. So we all know about hypoxia, and I'm not going to go into the physics of it. I'm sure all of us as physiologists have read about it. There is a fall in 1 degree centigrade with every 150 meters increase in altitude. Extreme dryness or low humidity, that is another factor which can contribute to, and the problems which happen because of this, you have increase, especially with all of us using a lot of smartphones and that kind of thing now, eye problems, a lot of, dry eye syndrome, pterygium, and nasal humidity, dehydration, lots of things happen because of this low humidity, which also scope for work. And there is increased solar and ionizing radiation because there's some more incidence of cancers and skin problems. Hypobaria, we all know about as we go up into altitude, how the middle ears get blocked and the equalization of pressure. Change in air quality, we like to think of these altitude areas as being unpolluted. A lot of wood smoke pollution is there. Some of the valley systems, they may create problems also. Wilderness creates its own problems because access to healthcare is not there. And sometimes people are not mentally prepared, that they are going to area where they're going to be lack of resources. So that is another aspect, extreme weather conditions and psychological stress. As much as we like to go and enjoy in some of these places, you don't get the comforts of modern life, many of them. And sometimes you may have to, older people may have to walk more joint stress, and so many other things are there also. So psychological stress also is there. So far research in high altitude was limited to mainly the military and to some mountaineering. It was a very niche area. And the main purpose of this research, which I was also involved in, was to improve performance in the military. Otherwise, most of the articles, most of the research work is basically been on mountaineering and done by mountaineers. So it provides a very limited window because most of these people are physically fit. They are already of a certain, mainly male also, very few women go to this area. And so it's a very limited kind of a area of research which was there till now. Most of the work that has been done also so far is on the diseases which are typical of high altitude travel, that is high altitude pulmonary edema, all of you may have heard of, which is actually in these days it's creating a lot of confusion with COVID because the presentation is really quite similar, and you have the lung findings you can see from this X-ray pretty similar, but a lot of work has been done on high altitude pulmonary edema, and even in our country from Defense Institute of Physiology, a huge body of work which is already there. And acute mountain sickness and high altitude cerebral edema, other two illnesses. Little less is known about high altitude cerebral edema because the incidence is quite low, but it is a fairly well researched and it's even in textbooks given in a good amount of detail. So what am I building up to? This is the current challenge that we are facing now, and unprecedented level of challenge. The number of pilgrims to high altitude shrines. We have hordes of unacclimatized elderly pilgrims with multiple comorbidities, which are traveling to all these shrines, the Kedarnath, Badrinath, Yamunotri, Gangotri, Amarnath, and they are basically they just come in these trucks and buses, and they are just not prepared for any of the environmental pressures that high altitude places. In addition to that, this is good money. I mean, it is basically, it is lifting the whole economy of the local area. So there are a number of local people who camp there during this period of increased tourist activity, pilgrimage activity, with their shops and their hotels and taxis. So many taxi drivers, they're all not, there's no kind of healthcare which has been given to them. There is no screening or testing. They're just going unprepared into these areas. It's a completely unregulated area. Also, besides pilgrimage, you have adventure tourism. So a lot of people are going now to Ladakh, to these higher altitude area for trekking, for even doing various things like paragliding and so forth. So this is a very good study population. This is where a lot of work needs to be done. So let's understand the extent of this problem, how much it is. I just want to share some data that I got this month from Kedarnath, and this is the report. Kedarnath altitude is, you can see it's about 3,000, more than 3,000 meters, and the gates opened on 6th of May this year. Okay, so this is the daily report on 29th of June. So, but roughly about 1 month, 1.5 months after the gates opened, 6th of May they opened. If you see, on one day, we had about 5,512, 3,320 males, 2,060 females, and 132 children. This many people came on one day to Kedarnath, which is at 3,300 meters. And total number of footfall in Kedarnath from 6th of May, that is over 1 month and 3 weeks, has been 8,27,255. So that is the magnitude and the number of people who are coming to these shrines and not coming with any kind of preparation or prior knowledge of high altitude illness. This is one day data from Yamunotri. Altitude is 3,293 meters. Yamunotri is a very dicey kind of a place in a way. I mean, I'm saying it not from the religious point of view, but otherwise, that it is a 5-kilometer steep trek. So people who have pre-existing heart disease, they're going into an area where there is hypoxia itself, which is creating its own stress, and they're also exercising and climbing. What are the numbers? In one day, 3,600 people came to trek up to one day, 3,600 people. And since the gates opened, 76,310 people. So this is huge. 53 buses, 380 cars. So that is the number of drivers who are also coming up to that particular area and undergoing after the travel time from Rishikesh to any of these shrines is 8 hours. So they're already going through 8 hours of rigorous travel. And after that, they're trying to do this climb, which is of 5 kilometers climb, steep climb. So this year, this is just I want this video to show that this is the crowd which has come to Kedarnath this year. This is the patient data. At Kedarnath on one day, on 4th of June, 1,230 people reported to a local hospital which is run by Swami Vivekanand Health Mission Society. We don't have much of a government hospital there. There is just this society which is somehow holding the flag of some kind of medical care out there. And in 1 month, this is the newspaper article which broke my heart. 98 people died. This is the state of affairs and this is, you can see the breakup of the people who had died. Kedarnath, 43 people died. And most of them have died of heart disease, but we don't know exactly what it is because we haven't got the entire breakup of the situation. On one day, there was a massive snowfall and people were not prepared. So they reported with hypothermia. So this Vivekanand hospital was inundated with people who came with hypothermia. So problems with the current medical evidence regarding high altitude, especially in people who are middle-aged with comorbidities like hypertension, heart disease, and COPD, respiratory diseases, is basically some anecdotal evidence is there, some very, very limited, well-planned clinical studies in altitude. Most of them are small sample size, like 15, 20 people at a time. They have been exposed to very limited altitude ranges for a very short duration. And there are some simulated studies. So we have absolute paucity of data. We don't know anything. So what are the lacunae? What are the research questions for these lowlanders with comorbidities and NCDs who are going to these, I said 8 lakh people in 1 month. Epidemiology and demographics. We don't know what is the breakup. So somebody needs to go down there and see what are the ages, what are the pre-existing diseases, what are male, female, whatever, the children, what are the demographics? What is the mortality post-mortem analysis? Those 93 people who passed away, what was the cause of death? Will the condition that they are going with, if there is a comorbidity, will it decompensate or aggravate in altitude, hypoxia, and cold? This is a very important question. That if somebody comes to you as a doctor also and asks, hey, should I've got hypertension for the last 6 years, it's controlled with the telmisartan. Should I go to travel to Kedarnath for darshan? It means also 14-kilometer trek. I don't know the answer myself. I don't know what to advise them, because any hypertension will get aggravated by entry into altitude. Because as you enter into hypoxic area, there is increased sympathetic discharge. There is direct effect of hypoxia on chemoreceptors. Blood pressure will go up, and how much it is going to go up, you cannot predict. If a person already has a heart which is subclinically it is got low reserves, low cardiac reserves, that person may precipitate a cardiac event. So as a doctor, I don't have anything. I don't know whether that condition would decompensate. Will that condition predispose to a higher incidence of any of the existing known diseases? In NCD, we don't know, because a person may already, because he has pulmonary hypertension or COPD or emphysema, he may be more prone to having high altitude pulmonary edema because the basic physiology is disturbed. So what do we need to do? What are the other questions which we looked at? We need to develop screening protocols before allowing travel to high altitude areas. This is one area which we need to have some guideline. What are the cutoff physiological reserves with which travel can be allowed after a medical consultation? We have to establish guidelines that a person who is not able to pass a hypoxia challenge test or a treadmill test, what exercise, what reserves are adequate for you to be able to travel to take on the hypoxia and some amount of physical exertion. So everybody can't do it. What possible modifications in dose of current medicines with which that altitude can be, travel can be permitted. So if I'm already hypertensive, what do I do? Do I increase my dose? Do I keep it the same? Do I monitor? So we need to work out that. What pharmacological interventions may improve acclimatization and ameliorate? We already know about Dimox. That's everybody. The child also knows about Dimox. But Dimox has got a limited role. It does not, then you have already got a person who has had a previous MI, a person who is hypertensive, a person who has COPD. What way can you tweak what intervention additional can you give? Should we give dexamethasone is well known to improve the condition. So can we increase, put a short course of dexamethasone? Can we give supplemental oxygen? Because some people say, whatever it is, I am going to go to Kedarnath. This is like mandatory for me. So in those conditions, we can support and, develop some pharmacological interventions by which we can allow people who are elderly with NCDs to go up to a certain limit. Other areas of research in this field is altitude and the elderly, women's health in altitude. We don't know anything about pregnancy in altitude. Very, very limited studies are there. Pediatric population, all by extrapolation, we have found our guidelines. Otherwise, pediatric cross-sectional and longitudinal studies are not available. Drug dose adjustment, anesthesia at altitude is also an area which needs to be seen. Do we need a different dose of various other medicines also when people are staying for a long period of time? Unpressurized air travel to altitude at locations and NCD. So this unpressurized air travel is another big issue, because many people these days are traveling by helicopters. So helicopter travel, actually you're going to a height which is higher than the altitude area. If you have to land in Kedarnath, you have to travel higher than Kedarnath. And there is no pressurization in these helicopters. Oxygen standards are not laid down, whether you're supposed to be given oxygen or not. The moment you land there, you're gone from a sea level to immediately to a higher altitude, and there you're immediately exercising because you have to get off the airfield. So this is again a very a big area which needs to be looked into and some guidelines developed. So this is an uncharted science to be explored for physiologists, something where if you have the guts to do it, because it requires you to go into these areas yourself, it is an opportunity to understand applied physiology and pathophysiology, each NCD, how it behaves from the organ level to the molecular genetic and in cold and hypoxia. Applications of this knowledge in sea level hypoxia. There are situations where we are dealing with, say, certain respiratory diseases and so forth, and applications in sports and performance. This sports, in training, sports training and hypoxia has been another old story which has been going on for a long time, and all the countries are doing it. So these are some specialty journals. Medicine and Biology and Journal of Travel Medicine, which are well, I mean, they're good impact factor journals. Some specialized funding agencies which will give you funds for this kind of work. LSRB is a Life Sciences Research Board, is under the DRDO. They have a special section of Physiology of Extreme Environment and Behavioral Sciences, which I am also there also as a member. ICMR has recently established a specialty panel for research in extreme environment. So these two, I know for sure that they are looking at funding these kind of projects, but most of the others, considering the need for the country right now, this is an area which you will get financial support. So this is just to show you I end my presentation with this photograph, which was taken last month when I traveled to Harsil. I'm presently working on adaptation in this tribe of there are people who have been living in high altitude area and are adapted to that area for a long time. So this is my current work which is going on, and I hope this has inspired a few of you to take up this challenge of research in high altitude. Thank you.
Thank you, madam. Thank you so much for a beautiful presentation, and that too from all your experiences. I am sure our all young generation, the young physiologists are highly benefited from this, and this will stimulate them to take up this new area of high altitude research. Thank you. Thank you so much.
Thank you.
Thank you very much, ma'am, for giving valuable insight on research in high altitude physiology. Thank you so much, ma'am.
Not this. Not this. No, yeah. This is in the.
It will be my honor to invite Dr. Murnal Fatak, ma'am, Professor and Head, Department of Physiology, Dean Academics, AIIMS Nagpur, Maharashtra, as a speaker for next session on electrodiagnostic investigations, nerve conduction, electromyography, and electrophysiology, assets to clinical neurophysiology research. Ma'am is having a total publications of 60 in both national and international peer-reviewed journals, and she is also recipient of Best Professor in Physiological Studies, awarded by 27th Business School Affair and Devang Mehta National Educational Awards, Regional Round, Nagpur. And she also received MedWorld Asia International Excellency Awards in 2018, and she is also a recipient of Best Teacher of First Year Faculty Award at Government Medical College, Nagpur, and Lifetime Achievement Award by Indian Organization. And she also has Fellowship of Royal College of Biology, United Kingdom, Fellowship of Association of Physiologists of India. She has authored 2 books, and she is also owns membership of professional organizations such as American Physiological Society, the Physiological Society UK, Association of Physiologists of India, Association of Physiologists and Pharmacologists of India, Academy of Physiology, Indian Medical Association. We welcome you, ma'am.
Good morning, Professor Mullan Phatak, and most welcome to the today's program.
Yes. Good morning, sir. Yeah.
Yes. Yes, you are audible. You can.
Yeah. Am I audible, sir?
Yes.
Can I
yes,
share
yes,
my
you are
screen? Yes.
Yeah.
Yes.
You
Okay.
can share your screen.
Yes. At the outset, sir, I would like to thank you for inviting me to be a part of this international webinar. And I heartily congratulate respected Professor G.K. Pal, sir, for his new achievement and excellent achievement. I'm sure AIMS Patna is going to be benefited by the kind of work and the kind of attitude that sir has in all the administrative as well as academic and research activities. So I wish him all the best. And I ask his permission.
Please go ahead.
Yes, sir. Thank you,
please
sir.
Go ahead.
Thank you, sir. Yeah. Is this okay, sir? Can I continue?
Yes, yeah, it is okay. You please continue.
Yes. Okay. So I will be giving you a brief interview about the electrodiagnostic investigations, particularly the nerve conduction velocity, EMG, EP. It's a very vast topic. Each component of this can be, a one-day's seminar. So it's a very Herculean task for me to complete this in 15 minutes, but I will try to do justice to that. Clinical neurophysiology is a core subset of physiology. It includes these three mainly: nerve conduction velocity, evoked potentials, electromyography. And why this is a subset of physiology, why this becomes an important domain for the physiologist to enter. This is because the base knowledge of neurophysiology, right from molecular to systems level, it is there with the physiologists. I don't say it is not there with the neurologists or the neurophysicians, but the physiologists are the best who study from molecular to system level, and the basics of neurophysiology are very clear for a neurophysiologist. At times, you need to do unorthodox tests depending on the presentation of the subject, on the patient who comes. And the fixed set or the fixed norms of actually going about with doing the NCV or the EMG and the subsets of nerves and muscles which need to be done for a particular disease, that cannot be followed. When you come into clinical domain, you have to apply your knowledge of neurophysiology and you have to add on the test or delete some tests. Now, electrodiagnostic studies in the nerve conduction velocities, they include the repetitive nerve stimulation, late responses, blink reflexes, and the needle electromyography. So we will not go into how this is all done. In each case, the study must be individualized based on the clinical examination and the differential diagnosis. And it has to be modified real time. As you start doing the test, it has to be modified. Many a times you get very unorthodox presentations and you have to do unorthodox or undocumented tests when you come into clinical practice. Even for research, when you go into research, you start with a particular disease and you start doing, and the patient presents to you with multiple presentations, you have to look into other aspects also. Basics of electrodiagnostic study, it is helpful in localizing the lesion, whether it is neuropathic, myopathic, at the neuromuscular junction, or higher up in the central nervous system. So these three varieties can be localized by these electrodiagnostic studies, whether it is neuropathic, whether there is a neuronopathy, radiculopathy, plexopathy, or so on. Whether the myopathic disorder is in the proximal region, distal region, craniobulbar, or it is generalized. And neuromuscular junction, whether it is presynaptic or postsynaptic. Now, coming to neuropathic, you can also understand by doing these nerve conduction velocities which type of fibers are involved, whether it is a sensory involvement in that disease, or it is a motor involvement of fibers, or it is a mixed type of fibers. Coming to pathology, it has implications in prognosis. We can diagnose and prognose whether it is an axonal degeneration or it is a demyelinating disorder. And the temporal course of the disease, whether it is acute or chronic, can also be assessed by the neuropathic investigations. Then coming to myopathic localization, you can localize the distribution of the disorder, whether it is proximal, distal, cranial bulbar, and also the severity of the involvement, and whether the pathology is a degenerative type of this or a myotonic discharge degeneration. Coming to the temporal course, again, you can know whether it is acute or chronic in myopathic disorders. In a neuromuscular junction, you can know the distribution of the disorder at the neuromuscular junction, whether it is proximal, generalized, or craniobulbar, and whether the pathology is presynaptic or postsynaptic. So these are some of the cardinal rules of doing the nerve conduction study and the electromyography. It always has to be correlated with the clinical examination. And if you are not getting the desired or expected results, you either look for some technical faults in conducting the test or the other technical factors, or you re-examine, start from all over again and take a complete clinical picture. It should be revisited. So never to overcall the diagnosis. That is a thing you have to remember while doing the nerve conduction studies as well as EMG studies. So these are the motor conduction studies. This is the motor action potential, which is long, having a positive and negative this. You see the amplitude, latency, and duration. You can calculate the latency of the conduction velocity by stimulating at two spots along the nerve, the proximal and the distal, and you record the motor action potential and know the velocity. Sensory action potential, again, it's a smaller one as compared to the motor one. You record it by stimulating the sensory nerve and you get the amplitude, the onset latency, peak latency, and the duration. There are some late responses which are also studied, which are very helpful. That is the F wave and the H reflex. The difference is that in the F wave, it is the antidromic conduction along the motor nerve. So you can see the motor axon is stimulated and the impulse is traveling antidromically along the same motor axon to come to the recording electrode to give you an F wave. Whereas in the H reflex, it is a reflex. So the sensory nerve is stimulated and it is a monosynaptic reflex where the stimulus is carried to the alpha motor neuron. And from there, it travels along the motor axon to reach the muscle where the recording electrode is placed. Now, how are these recordings and why they are useful? For F wave to be obtained, you need a supramaximal stimulus to be given to the sensory, to the motor nerve. And for the H reflex or the Hoffman reflex, you give a subthreshold stimulus to the sensory nerve. Now, F wave is not a reflex, whereas H reflex is a monosynaptic. We have seen the travel, how it travels. Now, F wave travels the alpha motor neuron pathway, whereas the H reflex follows the sensory and the alpha motor neuron pathway. Latency and persistence of the F wave are very variable. So you get variable F waves, whereas H reflex is a persistent response and it's a constant response. Amplitude of F wave is small and amplitude of H reflex is quite big. So these are some of the late responses which are recorded. Electromyography to see the health of the muscles and the nerve cells which are controlling that particular muscle. So this study is done. Parameters recorded are insertional activity, spontaneous activity, voluntary activity with two types of forces, moderate force as well as maximum force. Now, this is the insertional activity, which is normally recorded. It can be increased or decreased. We'll come to this later on. Then these are some of the spontaneous activities. Even though the muscle is not moving after the insertional activity, you get these abnormal responses. So this tells you about some sort of myopathic disorder in that particular muscle. Now, if you see the EMG findings in neurogenic and myogenic lesions, I would like to take a small 2 minutes on this. If you see the insertional activity of the EMG in a normal muscle and you see it in the neurogenic lesions, particularly in the lower motor neuron, you can see that it is increased. It is normal in upper motor neuron lesion and myopathic lesions, but it is disturbed or it is slowed in the myotonic lesions. and it is again increased in myositis. So increased insertional activity as you insert the needle into the muscle, it is very important to record what kind of activity is recorded as the needle goes through the belly of the muscle. Then you see the spontaneous activity, the muscle is at rest, no movement is occurring. Movements or spontaneous activity are only seen in lower motor neuron lesions and myositis. And the kind of abnormalities is either fibrillation or some sort of positive waves. Then you get motor unit potentials. Motor unit potentials, you see the durations normally. It is 0.5 to 1 millivolt is the amplitude and duration is 5 to 10 milliseconds. It is disturbed in all the lesions. It is disturbed in neuropathic low motor neuron lesions and myopathic lesions. You see the kind of responses that you get in the motor unit potential. Then there is interference pattern where the movement of the muscle is done. So interference pattern, depending on the movement, whether it is moderate force or high force, you get an increased amplitude of the interference pattern. And this is deranged in the neuropathic lesions. So these are the clinical applications of electrodiagnostic studies. In all these diseases, you can study how it changes, though you never get a typical book pattern when you come into practice. Every patient, every case is different, and you have to evaluate accordingly. Then coming to evoked potentials, there are sensory evoked potentials, motor evoked potentials, and event-related potentials. Now coming to sensory evoked potentials, there are visual, auditory, and somatosensory evoked potentials. Coming to visual evoked potentials, this is very important, actually, very less used as far as physiology or even ophthalmology is concerned, but it gives you a lot of information about the complete ophthalmic or visual pathway. So it is a non-invasive procedure, first and foremost. It gives you an excellent temporal resolution, and it correlates well with all the impulses being transmitted from the retina to the visual cortices. Visual processing not only involves the occipital lobe, but also involves the parietal and temporal lobe. So that also can be picked up by recording different areas, the VP from different areas of the scalp, extending from the vertex to the inion. This is how the shape of there are two positive waves, one positive wave and two negative waves, N75, N145. These are the two negative waves, and you get one positive wave, that is P100. You also record the amplitudes of all these waves and the latencies. Now, the basics and applications of visual evoked potential, it's very important. It gives you a very important diagnostic information regarding the functional integrity of the whole visual pathway. Then increments in latency with relatively preserved waveform morphology is a signal of a demyelinating morphology. Whereas distortions of morphology with no change in latency may transduce compressive lesions, which are compressing somewhere along the visual pathway. Pattern reversal is a favored stimulus for most clinical purposes, particularly in pediatric patients. It's very useful because the pediatric patients are not able to tell you or not able to discern what is happening. So pattern reversal is mainly used in pediatric patients. Flash VPs are useful when poor optics, lack of cooperation, poor vision, or malingering, or patients with nystagmus. So even for malingering, when students come to us for disability to get admission into MBBS, so this can be used to see if they are malingering the visual impairment. Two types of stimulation can be used, hemifield and full field. I'll not go into the details of this. These are different, and these are checkered or pattern VEP stimuli, which are given to either hemifield, right or left, and the full field stimulation. Coming to auditory evoked potential, it is again the auditory pathway. You can see here that there are a number of waves, right, from 1 to 7 or even 8 is recorded at times. The wave 1, abnormalities in the wave 1 and 2 tells you about the auditory cranial nerve, abnormalities of the cranial nerve, the auditory cranial nerve from the ear to the cochlear nuclei. Abnormalities of the cochlear nuclei can be diagnosed by abnormal configuration of wave 3. Wave 4 depicts the olivary nuclei. Wave 5, the lateral lemniscus. Wave 5 also tells about the inferior colliculi. So inferior colliculi and lateral lemniscus is taken together in wave 5. It's a very important wave, wave 5 anomalies. Then wave 6 and 7, the medial geniculate body, and 8 at times the auditory cortex. So you can see that the abnormalities of the waveforms of any of these waves specifically tells you where the lesion is in the auditory pathway. Similarly, the latencies are also seen, that how long it takes for the auditory impulse to actually traverse this particular auditory pathway. So that also can be ascertained, that can be known by knowing the latencies between the various waves. Coming to somatosensory evoked potentials, these are recorded from the central nervous system following stimulation of the peripheral nerves. So it is the sensory nerve which is being stimulated in the periphery, and the recordings are done from the central nervous system. Now, applications are to establish objective evidence of abnormality when signs and symptoms are equivocal. So many a times the signs and the symptoms are so confusing that we are not able to ascertain whether it is a neuropathic, myopathic, or a somatosensory, what kind of anomaly it is. Then to look for clinically silent lesions. So this is an area of research. To define an anatomical level of impairment along the pathway, and the pathways here which are depicted by the somatosensory evoked potentials are the proprioceptive pathways. Then to provide evidence about the general category of the pathology. Then coming to motor evoked potentials. Now motor evoked potentials are recorded from the muscles by direct stimulation of the motor cortex or by transcranial stimulation of the motor cortex. Now, this transcranial stimulation can be either magnetic or it can be electrical. Now, the magnetic stimulation is potentially used for clinical diagnostic applications, whereas the electrical stimulation is used for intraoperative monitoring of the pyramidal tract or the functional integrity of the pyramidal tract. It helps to diagnose disorder that affects the central and peripheral motor pathways, like multiple sclerosis, Parkinson's disease, CVA, and myopathy of the cervical and lumbar plexus. Now, the event-related potentials. Now, these are events which are occurring, which are recorded from the EEG signal. So, embedded in the EEG signal, there are small electrical responses which are specific to some tasks or events or stimuli or motor actions. You can use any type of events to produce these event-related potentials. One I would like to take here as a special case is the cognitive evoked potential. Now, the cognitive evoked potential is a long latency evoked potential, and it is an endogenous evoked potential. So you need endogenous stimuli to produce these type of potentials. So they can be either visual stimuli, olfactory stimuli, auditory stimuli, somatosensory stimuli, or pain. Now, this requires patient attention and cooperation, and it is not influenced by the frequency and intensity of stimuli. Applications are in age-related cognitive decline, dementia, psychiatric disorders, mental retardation, movement disorders, metabolic and toxic encephalopathies. So this is how the evoked potential or event potential looks, cognitive one. Now, what is target and what is non-target is, I will not go very much into the detail. Target one is, this is given in a randomized fashion, whether it is elective, it is or non-elective. Those type of stimuli are given randomly, and you see the variations in the recordings that are done at 300 milliseconds. So at 300 milliseconds is the one we see how much is the variability. One new domain of electro, the last two slides, sir, neuromuscular ultrasound. This is a new domain. Ultrasound is a practice of using sound waves to create an image. We all know high frequency one is used for neuromuscular structures, particularly nerves, and low frequency are used for muscle. Transducers having an adjustable range of frequencies, 18 to 6 millihertz transducers, are used for neuromuscular imaging. Applications, physicians who perform electrodiagnostic studies are best suited to learn and perform the neuromuscular ultrasound. it is essential to emphasize that neuromuscular ultrasound is complementary to electrodiagnostic studies, and they cannot replace the electrodiagnostic studies. This is because the electrodiagnostic studies are able to identify, like for example, they are able to identify ulnar neuropathy at the elbow, but they cannot discern whether what is the exact lesion which is causing this neuropathy. So this is where the neuromuscular ultrasound may help and may be critical or complementary to the electrodiagnostic studies. So like in such cases, it may reveal the bony spurs or the excess callus in the ulnar groove, or the aponeurosis, or the synovial compressing the ulnar nerves. So many of these etiologies can be picked up by the neuromuscular ultrasound after you have picked up the ulnar neuropathy in nerve conduction studies and the EMGs. So this is all from my side. I have tried to cover, and this has been very fast. I hope it is of help and people venture more and more into this clinical physiological aspect as well as research aspect of neurophysiology. Thank you, sir. Thank you so much.
Thank you, madam. It was a really nice presentation. I was really thinking how you'll do your justice in such a short time. But you have done a marvelous job, actually.
Thank you,
marvelous.
sir. Thank you.
No, I was really wondering before you started how you'll such a big topic you'll do in 15 minutes.
It's a big topic, sir. We can take, small seminars of each of these.
We'll do in future. We'll take up all these things in small these things.
Yes, sir. I would like to excuse myself for my question answer session because I've got a video conferencing with AIMS Jodhpur director. So at 12 o'clock, I won't be available.
Please go ahead. No problem.
Any questions on my mail you can send. I will.
We'll send you a mail, madam, and you can answer them.
Thank you, sir. Thank you so much.
Thank you, madam.
Thank you very much, ma'am, for enlightening us on electrodiagnostic investigations as an asset to clinical neurophysiology research. Thank you very much, ma'am. Today, we have a splendid presence of Dr. Shripad B. Deshpande, sir, Emeritus of Physiology and Consultant, Apollo Institute of Medical Sciences and Research, Chittoor, Andhra Pradesh. Now, may I request Dr. Deshpande, sir, as a speaker for next session on assessment of neurotoxicity in clinical physiology research setup, the application and future scopes, with special reference to scorpion venom. Sir is having an experience of more than 46 years as a teaching experience, and he is an experimental physiologist, published more than 155 papers in peer-reviewed journals with an impact factor of 250, an H index of 21, an I-10 index of 45. Sir is also a recipient of more than 20 national awards, which includes Major General Bhatia Oration of Association of Physiologists and Pharmacologists of India, Professor Baladev Singh Oration Award of Association of Physiologists and Pharmacologists of India, Professor R.C. Shukla Oration at King's George Medical University, Lucknow, and Vice Chancellor's Research Award at Banaras University. Sir's key areas of research includes ARDS, scorpion envenomation, neuroscience, neurophysiology, neurodegenerative disease, Huntington's disease, cellular model, spinal synaptic transmission, and network. Bisphenol A, a toxic chemical from plastic, utrotonics, anoxia, ischemia, and chemical anoxia. Sir is also founder president of Association of Physiologists of India, member of International Committee of Scorpion Venom, standing committee member of NIMIS of HRD of Government of India, and assessor of NAC, guest faculty at IBRO workshop at Mahidol, Thailand and Sri Lanka. We welcome you, sir.
Namaste. Sir, namaskar, sir, namaskar. Namaste. We are blessed to have your presence in our webinar today.
Actually, thank you so much. And rather, I wanted to be, it's a good thing that I am joining here. It is a joyous moment for me because we are felicitating you on this occasion, and we are really proud of you and your achievement. all the members of the SOP and the physiologists will take pride in your achievements. Congratulations, Dr. Paul, and hope you will do much better and you will reach the newer heights.
Thank you, sir. Thank you.
Having said that, maybe I am more happy. Perhaps you are less happy because when I am telling you are stressful, I am not stressful. Because I don't have a stress and you have a stress. Anyway, you will overcome that and we will enjoy these things. Before I take the Mrinan Pathak has taken away all my whatever the topics I wanted to talk. Okay, so just let me share my screen.
Yes, sir. Correct. We'll do. Just come.
You see my screen now?
Yeah, yes, it is visible and you are audible also. Please go ahead.
So now, let me tell Dr. Mrinan Pathak has already mentioned everything what I wanted to tell, and my job is made easy. Now I can just give a broad outline of the things I can go around. See, I have been working in neurophysiology, especially neurotoxicology, for longer. Initially, I started with neurotoxicology work in vitro. Most of my studies are in vitro models, either a synaptic model or a cellular model or models in experimental animals. I started with the organophosphorus, most dangerous organophosphorus compounds in the United States of America, serine, chromium, EX. These are some of the defense-related organophosphorus compounds, and we were trying to screen for some antidotes during that time. Then also we were trying to screen some drugs of abuse. That was a part of the US Addictive department. Then I came back to India. Then I started with the scorpion venom. I will not talk about the scorpion venom on this day. Then I was having a DRDO projects with even the organophosphorus compounds. In addition, we were trying to have some other toxins, chemical toxins synthesized by the Defense Research Development Establishment, Gwalior. That is what is called a Trichodiscus brevis toxin. That is one of those toxins we were trying to see. We were trying to screen. Meanwhile, the Geneva Convention banned all the chemical warfare agents. So then that project, we did some work and we published a good number of papers on that, and we established certain things. Then later on, I joined, I just did the toxicity studies using the 3-nitropropionic acid and on the cellular activity and so on and so forth. So this is briefly about my toxicity journey. Now, neurotoxicity, what is neurotoxicity? It is the toxic effects on the neuron or its parts. Axons, dendrites, nerve fibers, synapse, or glia. Any component in the nervous system can be reviewed or can be studied. And any alterations in the neuron or its parts results in the alteration in the functionality of the whatever the entire system, even nervous system or particular areas of the nervous system. It is manifesting as an altered sensorium or altered autonomic abnormalities or altered cognitive aspects or altered behaviors. So those are some of the outlines of the neurotoxicity. Thus, clinical assessment involves to assess all of these components. The neurons, if you are coming back, how to assess the clinical assessment of the neurons, assessing the functions in general, the specific area functions at various levels. That is one we can assess a particular area. Say, for example, if I am looking at the cerebellum, then I will just go to the cerebellum and try to see the cerebellar functions. And in that, what Dr. Mrinal Pathak has not brought in. Now we have to look into the next higher level, that is looking at the functional aspect of the organ systems. So what we have these MRIs or functional MRIs, where the synaptic transmission in question of a particular area, or where the metabolism of a particular area of the brain by performing certain actions, we can study how those metabolism are affected by the neurotoxicity or by any altered physiological states. So fMRI is one of those wonderful things, maybe expensive. Now we have so many aims coming up, and each of these aims they can venture for getting the fMRIs and trying to understand more at the basic level at a particular area, wherein you can also see the neurons happening. So all these electrophysiological studies have their own limitations. Here you will see the areas in which they are affected, and then we can look at that. And whatever the setup requirements for these fMRIs is whatever the MRI setups is the markers. That is the main thing. Then about the nerve fiber functions, I will not waste my time here. Dr. Mrinal Pathak has done it very well, and I have not more to say about that. So if they're going for a conduction velocity, what has not been mentioned in the strength duration curve, because the strength duration curve gives another aspect in the nerve fiber activity, especially in the neurotoxic level or neurodegenerative levels. So one has to do the strength duration curve, trying to identify the threshold. So setups, you require basic electrophysiological setups. Then synaptic level, we can assess the neurotoxicity at the synaptic level. This is the easily available synapses are the neuromuscular junction and the 1A alpha motor neuron synapse, because these are accessible or we have that. So the neuromuscular junction is very well studied, and the 1A alpha motor neuron synapse is studied by using that Hr reflex. It's almost similar to, it's exactly the electrophysiological component of the stretch reflex. And you can also study the event-related potentials where the number of synaptic components are involved. It's not only one synapse. In case of Hr reflex, it is one synapse. 1A alpha motor neuron synapse. If you are looking at event-related things, there are so many things, so many synapses are involved, and you have to these things. So in that, auditory event-related stimulus para is one of those things wherein you can see at the different levels. And you can also see the visual, auditory, and the sensory reaction times and the evoked potentials. Again, you require the electrophysiological recording things. And let me tell to my friends that I worked with the medical electrophysiology, and if you have a mind, you can generate. And even whenever the ADI person visited the Institute of Medical Sciences, Banaras University, he was always scared, sir, what is the new alteration you have made, or what is the fabrication you have made to our instrument, ADI instrument. So now we have to sit with the instrument and understand how things work, and we can exploit each of the things. So now coming back here, this is the schematic representation of the Hr reflex. I will not take my time. We have the you stimulate a subthreshold or threshold stimulation will activate the 1A fibers and then activate the motor neuron. we studied, so we did a certain amount of the toxicity studies in animals on the nerve, in vitro nerve, and in the heart, and in this thing. Here, I am just trying to show you in an animal how we recorded the Hr reflex, and this is how we recorded. This is a stimulating electrode, and we have this electrode is placed here on the muscles here, the small muscles of the fingers, toes fingers, and then we have a recording system, and we stimulate it, and we got this is actually what we got in our experimental setup. So we have got this is the stimulus artifact here, this is the M wave, and then after latency, we have this Hr reflex. Of course, you cannot just translate it into the human beings. Whereas this, if you are looking at the distance between the two stimulating electrode and the entire synaptic pathway, entire distance is much less as compared to human beings. In that way, the latencies are lesser. Now, coming back here, the same experiments, what we did, we exposed the animals with the plastic. The BPA. We just made the animals to eat the BPA pellets, and we gave the pellets. And after giving the pellets, this is a placebo control. You can see that Hr reflex how this is remaining same, 0 in the initial stage. After 3 weeks, after 6 weeks, it is normal. This is control. And in a BPA fed animal, you can see this is the initial, that is the control level. Then after that, after 3 weeks of the BPA and after 6 weeks of the BPA, you can just see that the Hr reflex is diminished, and these are shown here in these bars. Okay, I will not go into the detail of that. And similarly, what we did, we also took the plastic available in the local market, and we boiled them. And after boiling them, we gave the boiled water to some group of rats. So now we have these group of rats. One is fed rats, one is the plastic leached water. This is the bottom line is the plastic leached water. We found again a similar type of phenomena, the plastic leached water. The same, you can just see that the Hr reflex was diminished, whereas the M response was not altered. M response is nothing but the transmission of because of the high threshold. Now, this is a Bera. Professor Kotak has done well with that, and I will skip this particular slide. And another important aspect of the neurotoxicity assessment is a battery of autonomic function tests. Because autonomic functions cannot be isolated from the nervous system, or the autonomic system cannot be isolated from the nervous system, because autonomic system generates from the what we call from the limbic system or the amygdala, hypothalamus, those components. So that means anything happens in this world would alter the autonomic function. So we have to screen how we respond to the external world, so that autonomic functions will be the one which we can think about. And we have a number of tests I would not go into. So I am just adding up, maybe sweating response is not studied in the Indian context, because many of them are looking at the RR intervals or whatever the components associated with ECG, or beat to beat variations, or in response to baroreceptor activation. And less number of papers I have seen with the chemoreceptor activation, and many more. I would say that we should concentrate on the chemoreceptor activation and sweating response. Sweating response is also another autonomic response. And this could be studied very easily, just how the sweating happens. You don't require extra setup for that. You have to just take up, and very simple experiments are there. You can just scan it, or you can contact me when you want to come back. Sweating response is one of the important things which talks about the autonomic functions. Then cognitive functions. Neurotoxicity can be assessed by the cognitive functions, performing tasks or solving problems, stool tests, many more. Maybe you have to decide, sit back and think and analyze. Then other behavioral tests. These are anxiety tests or irritability or depression models or aggressive responses, sleep-wake cycles, biological rhythms, their memory and learning and many. All these things will be altered because of the neurotoxicity. Now, to summarize, broadly can be categorized into two. Definitive tests are the altered neuronal, axonal, and synaptic or glial functions. Assessed electrophysiologically or chemically by using the molecular biology models. That means you take the samples and develop the antibodies and you block, and maybe it is your imagination or it is how you want to go around. So electrophysiologically, we are acquainted or we have been told this lecture and previous lecture. And at the chemically, the molecular level, so you have to design clinically at the molecular level the antibodies or any chemicals evolving, or the free radicals or any other chemicals which are coming up, or structurally using the imaging tests. Now we have to exploit these two, the latter two aspects for our even studies, physiological studies in altered situations. Then the behavioral and autonomic and the cognitive tests are mostly presumptive. Why I'm saying the presumptive? Because any damn thing on the earth can alter these things. So for that reason, you cannot be a definitive for these things, and you just associate something which has happened, and because of this thing, this might have happened. So you never say that this has happened because of this. So that is why it's a presumptive test. And now you have to associate these behavioral tests along with the definitive tests, then you can come up with a good proposal or a project or a paper, whatever. Okay, thank you all. Thank you for hearing. And I again congratulate Dr. Paul. So I will be there with you, I think, by phone call.
Yeah. Thank you, Professor Deshpande, for a brilliant presentation. And you have done exactly in 15 minutes. Brilliant talk, and that too from all your works and all your experience, and so nice. Thank you so much, sir.
Thank you. And now I am not in Chittoor. I am just with my brother's house in Gadag. Okay. I again take excuse that I may not be available for question and answer session. I think I would be now to receive any messages. I will check the messages, or you can give the messages to me. I will respond to them.
Sure. Okay, sir. Okay. Thank you, sir.
Okay. All the best.
Thank you, sir.
Thank you very much, sir, for enlightening us about assessment of neurotoxicity in clinical physiology research. The session was full of valuable knowledge. Thank you very much, sir. Now, it will be my privilege to invite Dr. Prasanta Pradhan, sir, Professor of Nuclear Medicine and Head of Telemedicine Center, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, Uttar Pradesh, as a speaker for next session on Nuclear Medicine, a Physiology and Biophysics tool for clinical and research investigations. Sir has PubMed indexed publications around 49, and he has also co-authored for 2 books and 9 book chapters in nuclear endocrinology and cardiology. He is also editorial board member and reviewer to many national and international journals. Sir is also a recipient of Homi Bhabha Oration Award presented by Society of Nuclear Medicine, India. He is also a member, past president of Society of Nuclear Medicine, India, past president of Nuclear Cardiology Society of India, Senate member of Asian Nuclear Medicine Board, Korea, and he is also president, Telemedicine Society of India. Sir's major achievement includes Commonwealth Fellow, Nuclear Cardiology, Imperial College of London. We welcome you, sir.
Prasanta,
Yeah. Good morning.
Yes. Just a minute, Prasanta. Prasanta is new to this audience. He is from SGPGI, a great, I'll say the great clinician in nuclear medicine. And he has actually a lot of achievements. He is president of many, nuclear medicine organizations. And his special interest actually, apart from nuclear medicine, is this telemedicine. And he is heading the department of the Center of Telemedicine and he has a lot of interest and he has contributed a lot. In fact, now currently he's the president of Association of Telemedicine of our country. And Prasanta actually is a great, a scientist, researcher, and clinician. And behind a great person, there must be a great woman. And I just wanted to introduce his wife, Mandakini, is also from native place, the VSS Medical College, Burla, and both of them are working there. Dr. Mandakini is there as head of the Department of Obstetrics and Gynecology and the best clinician in genetics. And both of them are doing so well. And I'm really so happy, Prasanta, that in spite of your hectic schedule, you have been traveling, I know, and in spite of that, you have given some time to us and you're looking to us. Thank you, Prasanta, please.
Okay, thank you very much. Thank you very much. Let me share my screen.
Yeah, sure.
Good morning to all of you. Am I audible? Am I audible?
Yes, you are audible. You are audible.
Yeah, my slides are on.
Yeah, your slides are also visible, clear.
Okay. 1 second, just. Can you make it so? Good morning. I must thank Association of Physiologists of India and Professor Gopal Pal also, who is a very close friend of mine. We grew together in MBBS from BSS Medical College, Burla. Gopal, for all the information of the physiologist, I think I have tried my best to enjoy what is nuclear medicine. And with a little varied interest, may not be a great researcher, really true, but still I will take you through 15 minutes some journey, what really nuclear medicine, how you integrate physiology and biochemistry and biophysics to the nuclear medicine actually. That's my topic. Coming to nuclear medicine is by and large an in vivo functional imaging and a therapeutic discipline, which we give also the internal radioisotopic therapy for different disorders like mostly thyroid cancer, prostate cancer, and the neuroendocrine cancers and the refractory lymphomas. Coming to the nuclear medicine, the imaging aspects, which constitutes almost around more than 85%, this is mostly with a planar imaging, like a two-dimensional imaging, which I will show you later, and the SPECT called a single photon emission computed tomography, like a three-dimensional imaging, and also the PET scan is a four-dimensional imaging. Why four-dimensional is you can also add a respiratory getting to the PET, that is 3+1. That's how it is a four-dimensional imaging. Coming to the therapy part, most radioisotopic therapy are internalized to the cell and they give the beta emitter or alpha emitters recently in the book. Earlier days, whatever you must have listened is mostly with the workhorse is iodine-131, radioiodine, and subsequently lutetium-177 dotatate for neuroendocrine tumor and dotatate and lutetium-177 PSMA, prostate-specific membrane antigen. These are the two isotopes, the radiopharmaceutical which came for prostate cancer and also for neuroendocrine tumor. And yttrium-90 is also combined with the similar chemical ligands for treatment of this prostate cancer and neuroendocrine tumor. And for all of your information, so these are metastatic for the neuroendocrine tumor and prostate cancer. But recently, those patients who really doesn't get remitted, no remission is there with the beta emitter, we can also treat them in alpha emitters. I think this image here has gone to AIIMS, New Delhi, in the world from Society of Nuclear Medicine, USA, with actinium-225 dotatate for the treatment of pheochromocytoma and paraganglioma. Coming to the tomographic imaging, if you have with the availability of tomographic imaging, in the form of SPECT and PET, it is possible to study the molecular dynamics of the body in a three-dimensional manner. Various radiotracers already I have told you are available, which can help you to study the molecular basis of various oncologic as well as non-oncologic disease. You can timely and accurate management of various diseases you can do by utilizing these methods. This is just a picture of a SPECT CT. It is a gamma camera with the facility of SPECT as well as the CT scan is combined. This is known as otherwise hybrid imaging. And this is a planar bone scan just to see. In a planar bone scan, sometimes you see the optic, but you cannot delineate much more. If you combine with a SPECT, and this is a SPECT, the radioisotopic hotspot, combined with a CT scan, you can characterize furthermore. That's how the SPECT CT came for understanding the functional and anatomic images. And you see the fusion images. And coming to the thyroid, it is the most important organ which has been, in fact, the inception of nuclear medicine started with the thyroid gland. And in physiology, I think you are all well versed. I think these thyroids, a simple picture, this is a autonomously functioning thyroid nodule. This is a multinodular toxic goiter, and this is a thyroiditis. A simple thyroid scan can distinguish following the biochemical parameters between all these diseases, and the basis of it is basically the sodium active transport of iodide or a technetium, which are almost biologically similar, excepting the organification. That it is the basis is basically sodium iodide importer gene located in the basolateral membrane of the follicular cell. And that NIS is the basis which really earlier we knew before 1996 that sodium iodide importer is the active transport does happen by iodine from the vascular pool to the follicular cell, but subsequently it is by NIS. It has been determined by Nancy Carrasco group from Albert Einstein College from New York, and subsequently there are more than 500 publications on NIS now, you will see. In fact, this thyroid scan, many people think that the PET scan is molecular imaging, but I always say that it is the thyroid scan which is molecular imaging, where the nuclear medicine has inception. I'll show you a picture which has been published by a group from both, I think, US and as well as JIPMER. Pondicherry is a case report by one of our Dr. Dhanpati is also there. You see this thyroid scan, which is depicted, doesn't concentrate. You know, NIS is expressed in thyroid gland as well as stomach and salivary gland. And if you don't see them, then you can say that this is a NIS defect, that is the genetic defect. That's why the thyroid, simple thyroid scan is a molecular imaging. Technetium, and after can take the scan, simple it is, no much of preparation. Yes, sir.
Sir, you are not audible, sir. Sir, can you hear us?
Sir, I think you have some connection problems, sir.
Sorry for the inconvenience. There is some network issue with the sir. We will rectify it soon. Sorry for the inconvenience.
Hello.
Yes, sir. You are audible, sir.
Yeah. Are you seeing my screen?
Yes, sir.
Okay. Sorry for the interruption. Connectivity is the problem. Okay, this is a slide which depicts basically the methoxy isobutyl isonitrate labeled with technetium to go for parathyroid adenoma localization, which is very common now. You can combine with your ultrasound and the MIB imaging, and you can localize the parathyroid. They basically not to really diagnose, it is basically for co-localization, so that your turnaround time of the and the next is coming to these are all the SPECT scan basically for the heart. These are cross-sectional section, and you can see the gating movement, the wall motion movement of this, from where you can say whether there is a hypokinesia or akinesia. Similarly, you can also quantitate with a computer rendered 3D image of left ventricular surfaces of the heart. So these are the images you can get. Similarly, also brain, you can see there is a hypoperfusion area. I think you can see very well in the parietal lobe as well as the postparietal and anteparietal lobe. And you see these SPECT images basically represent the hypoperfusion, whereas it is the MR if you do this also shows. And similarly, PET CT and PET MR. You know, the positron emission tomography is combined. This is a functional imaging combined with a structural modality, either CT or MR. And this creates images of physiologic processes using positron isotopes. And PET scanner is traditionally combined with a CT, and this for a complementary images of physiology, anatomy, and provide one-stop imaging of function and structures. And I think this and this is an image of cyclotron where we produces the fluorine 18, the most ubiquitous radiopharmaceutical for the isotopes for PET scanning. That's why this is basically to orient this. And now with this, you can also see some generator produced radionuclides, which are produced called gallium-68, which is very commonly utilized now for neuroendocrine tumor imaging and prostate cancer imaging, and also many pathophysiological processes. This is 68-minute half-life. This comes as a generator. You can utilize for almost 6 months of this is a gallium, and now these are synthetic module for peptide synthesis. Mostly these positron emitters are combined with the peptide, and you can generate that radiopharmaceutical of choice, and you can understand the pathophysiological imaging. Coming to the positron emission, why we say single photon emission computerized tomography, and PET is a 2 photons actually in a very high energy of 511 keV. That is known as annihilation photons, and you can see the PET imaging. And this is the whole body PET scanner. What you see the imaging, okay? And you can see this is heart utilization and other structure also. This is just to depict you that this is the sagittal image, the coronal image, and the transaxial image you can see. And this is a MIP image. This is called maximum intensity projected image. And this is basically to depict the glucose utilization, which is mostly done with a PET CT scanner. This is the picture of a PET CT scanner where you basically scan them. And this is the basis, the rationale behind the physiology is basically the glucose also enters to the cell, and it is metabolized coming to the glucose phosphate, then glycolysis, then produces the carbon dioxide, water, and energy. Whereas the FDG, fluorodeoxyglucose, which is F18, half-life of 120 minutes. It goes through the cell glucose transporter. That is, there are many transporters, GLUT1 to 8. And you can see that the FDG doesn't have a fate. It is trapped inside the cell intracellularly. Then subsequently, you can see the image. The advantages of PET are this is whole body imaging. It is a non-invasive procedure. You just have to give an injection, shorter procedural time, ability to incorporate isotopes into tracers of physiological interest, intrinsically quantifiable. You can do also absolute quantification, better tissue penetration of the photons, and a better image quality because of the better resolution than the SPECT imaging. That's what is indicated. Coming to the indications for PET imaging, in nutshell, I can say the oncology forms the basis for 90% of referral of PET CT. Rest are for infection imaging or some pathophysiological processes imaging like cell receptor SST or somatostatin receptor imaging or prostate cancer PSMA imaging like that, or RGD SPECT imaging. Many chemokine receptors are also imaged with the PET scan imaging in the lymphomas. Coming to this image, I think you must have heard recently the fibrous associated protein is also generated in the production in the malignancy. So recently there are a lot of works going on in the FAPI imaging. This is called fibrous associated protein imaging. And this is the image of this year. And you can see the once a patient has a heart attack, and you can see anterior myocardial infarction. This is the apex of the heart. This is the short axis. This is the horizontal long axis, the vertical long axis. This is by SPECT scan, the first row. This is a polar map showing the defect. And also this is a SPECT scan, PET scan. Then the SPECT and the PET are combined. And you can see the FAPI, the fibrous associated protein, which depicts the fibrosis. And it is compared with the MRI, gadolinium. And you can see this white one, the line, the fibrous, the anterior myocardial infarct, and it has been shown that the anterior myocardial infarct is much more in size in comparison to with the FAPI, that is fibrous associated protein 43 combined with the gallium, and this has been declared as the image of this year just recently in Vancouver, USA. So you can understand many pathophysiological processes with nuclear medicine imaging. That's how we should integrate the physiology and biochemistry together. Coming to the myocardial functions, you can also measure calcium score from the CT part, the perfusion from nuclear medicine imaging part, looking at the blood flow. People utilize ammonia or rubidium or oxygen, and now also there is a newer agent called flurpiridaz. And the viability is also utilized because the heart utilizes when they are viable, the myocytes are living, they utilize mostly the glucose. That's why if they are dead, they are not viable or scarred, they will definitely not utilize. That can be also studied, and this is clinically done routinely now in the PET scan imaging for heart viability following post-myocardial infarction. You can also see that you can see the fluorothyramidine. There is a radiopharmaceutical with a PET tracer. You can see from this image first, it is hardly seen. It is a benign inflammatory lesion. When you see a little bit more, it is a squamous cell carcinoma. When you see much more, it is a non-small cell lung cancer. And when you see very high uptake, this is called undifferentiated large cell carcinoma. From this, that reflect the Ki-67 score index, which is done mostly in the pathology. And this you can see how PET depicts from benign inflammatory lesion to the malignancy. These pathophysiological processes can be really nicely studied with PET imaging. And coming to the next slide, please. I'm just depicting you how the PET scan. You see, this is a baseline gallium-68 DOTANOC scan showing multiple metastases in the liver in a patient of neuroendocrine tumor. Can you see? These are the cross-sectional section. This is the MIP, maximum intensity projected image. And subsequently following lutetium-177 DOTA-TET therapy, after giving 2 cycles, we did another imaging of the patient, and you can see how it has reduced in comparison to this. This is known as a partial response to therapy following lutetium DOTA-TET therapy. Then the patient will be given another 3 cycles of therapy. Similarly, you can also study it in breast carcinoma fluoroestradiol therapy, that is FES, fluoroestradiol. You can see that how FES and FDG, these are two radiopharmaceutical for PET imaging. They depict different things. If you have one, like you are imaging FDG, but you are not getting FES, that means the estrogen receptor is not depicted here. That means estrogen progesterone receptor also you can monitor with to direct the basically cancer therapy in PET imaging. And PET is utilized for staging, not for many diagnoses excepting unknown primary. It is mostly for staging and response to chemotherapy. Coming to medullary thyroid carcinoma, I am just giving you an example that we see a uptake here. You can see this very small uptake, and also you see a pituitary uptake, which is normal actually, biodistribution. And subsequently, you can see this is a fusion image showing a paravertebral tissue here in the shadow, almost a D6 vertebra with the gallium PET scan. And you know, sometimes the CT scan lag behind this uptake. You may not depict in the CT scan, but you in the functional PET scan, you can find the uptake. That's the time you should biopsy these lesions to prove that they are metastases. But in clinical scenario, normally people say that there should be structural changes so that this clinician believes. But for us, if you find a metabolic abnormality or increased uptake, that means we should we should change that lesion and do a biopsy. And in our own department, we utilize robotic PET guided biopsy for further characterizing the lesions to be metastatic or to of a benign lesion. That's why I always say PET never lies. PET basically guides you for further care. Coming to the therapy part, I think radiopharmaceutical therapy, I have already told you, basically through biological targeting, it provides a unique means to efficiently deliver ionizing radiation to disseminated cancer cells and small metastases while sparing healthy normal tissues, which happens normally with radiotherapy. But with the internal radioisotopic therapy like nuclear medicine, it exactly provides the therapy to the metastatic cells. So radiopharmaceutical therapy sits at the junction of chemistry, radiobiology, immunology, cell biology, diagnostic imaging, physics, and multiple aspects of pharmacology. So thus appropriate assessment of radiation doses also is equally important in the tumor and the normal tissues, is very crucial for radiopharmaceutical therapy. Now we are currently doing with iodine-131 for thyroid cancer, thyrotoxicosis, for prostate cancer with lutetium-170 PSMA. For neuroendocrine tumor, we are utilizing lutetium-177 DOTA-TET therapy for these radiopharmaceuticals. This is the list. I will not go into detail. Yttrium-90 is also utilized. For palliative pain, bone pain therapy is also utilized. And I am not going to their half-lives and physical properties. This is just a picture to show you, impress upon you that how alpha emitter is utilized with bismuth 213 DOTA-TOC. I told you there is a recent award to All India Institute by Professor Bal et al. Group, and I think they have done a marvelous work. Actinium-225 DOTA-TET, they have really given to the patients, and this is a seminal work which is awarded many times now. His PhD student is also awarded with another Morrison Award. So this is a contribution. I think now coming to the research, this iodine-131 understanding for many benign and malignant thyroid disorders gives us the basis that HNIS, human NIS, I already told you. This we wanted to study that the human NIS is expressed in thyroid, salivary gland, stomach, and also in extrathyroidal tissue like breast, kidney, and lung. And the breast tumor and thyroid tissues share very common properties as they express both the TPO gene and NIS genes, which has been published way back in 1998. So what we wanted to understand is through a PhD thesis, the sodium iodide sympator expression in breast cancer, which has been published, the functional expression of HNIS in breast cancer tissue. We did the radionuclide imaging, the breast cancer tissue, immunohistochemistry, RNase protection assay, Western blot analysis, iodine organification, and a hormonal relationship, which I will come one after other. This is a breast imaging in a breast cancer patient. You can see the uptake here. What we demonstrated first from India that this TPT uptake, normally there was a publication in Nature in 2000. They told that this is in a transgenic mouse model. NIS is suppressed by the expression, is uptake is suppressed by the technetium uptake, is suppressed by perchlorate. But a human model, when we did 15 patients, we didn't realize that it is not suppressed by perchlorate. Then we told that there must be another pathway for this, and we demonstrated them later showing this uptake, and we quantitated them semi-quantitatively, and we demonstrated them it is not blocked by the perchlorate, the NIS uptake, though this pathway in the and now this is just to quantify and show this. And this is RNA protection assay where we assess. This is the tumor tissue depicting this protein, NIS protein, and this is the control. And these are the RNA protection assay. That means we are saying that the breast cancer tissue exaggeratedly express the NIS protein. And this tumor, again, you will see this is around 97 kilodalton. And this is the control, molecular weight markers. And we also demonstrated the iodine organification in breast tissue, which is not suppressed by the perchlorate. That also we demonstrated. So this gives an evidence along with the nuclear medicine scan, every aspect of this. This is how, and we also do the tumoral tissue, extracellular tumor. This is the tumor tissue depicting the, you see, immunohistochemical staining for NIS, and so that there is the NIS is positive in the cytoplasm instead of the nucleus. And we also demonstrated there is no hormonal relationship of thyroid hormone and protein along with these breast cancer tissues. Then we realized that there is enhanced concentration of technetium pertechnetate in breast tumor, suggesting high NIS expression. And this technetium uptake is significantly suppressed by perchlorate in thyroid, but not in tumor tissue of breast, suggesting a different mechanism of handling of potassium perchlorate by NIS, which was, and this perchlorate blockade might help in radioiodine imaging and therapy to block other organs expressing sodium iodide sympater like thyroid, stomach, and salivary gland, which was highlighted in the 2002 this Society of Nuclear Medicine US Congress, where I was presenting this paper. And subsequently it has been published and it is highly cited now, more than 60 times. And on that basis, you can also transfect the NIS gene to a mouse model, and you can scan them. This is called theranostic. You can scan as well as you can give therapy to the tumor. And you can also see there are multiple therapy applications you can do. Similarly, all these biological processes, you can image with SPECT and PET. These are animal imaging for the basically SPECT and PET equipment which has been combined. And you can see the biodistribution of the radiopharmaceutical prior to the clinical trials. And you can also see the wall motion of the heart and the uptake, anatomy and molecular kinetics can be depreciated. You can also see pharmacokinetics, like in seconds, this is 0 to 3600 seconds. You can see that how a radiopharmaceutical have different pharmacokinetics. These also can be quantitated, and this can be seen how it is biodistributed in the mouse model or anything. This is also interesting that any pathophysiological processes you want to understand, you can utilize the radiopharmaceutical of interest. Similarly, you can utilize even 4 radiopharmaceutical together of different, and you can do a simultaneous quadruple isotope SPECT-CT or a PET-CT imaging. That's what the power of nuclear medicine in research. Thank you very much for patient listening. Hope, I think this basically impress upon you that what nuclear medicine can do wonder for the research of physiology and biochemistry, and you can integrate them. I think I will not be available because of actually engaged in multiple occasions, but I could not say no to Professor Gopal Pal, who requested me as a close friend. I thought, okay, let me share with you. But in future, given an opportunity, I think I will be able to explain you in detail more about the nuclear medicine and the research.
Thank you so much, Prasanto. It was really a wonderful presentation. And this is a kind of new type of presentation to the physiologists. But I wanted you to speak because nowadays this functional, structural, anatomical, all research in physiology, and not only in physiology, cardiology, neurology, all actually depends on this nuclear medicine and the investigations done in the nuclear medicine. That is really a sensitizing talk to the physiologists. And I'll tell you this, your positron emission tomography, PET scan, these are all biophysics and physiology. So now the time has come. Yeah, now the time has come. The physiologists to now enter into this domain and keep the collaborators in research from nuclear medicine, from radiodiagnosis department, and do the quality research. I have seen actually from my experience. We did one small, involving your nuclear medicine person, Dr. Dhanapati, and we had a beautiful work actually. So, I mean, this once you add nuclear medicine into physiology research, your publications will be really in very high impact factor journal. Thank you so much for sharing your time, your knowledge, your experience, your expertise. It is really, I mean, eye-opening to all of us, and it will be a great asset for us in future. Thank you so much, Prashant. Thank you.
Okay, okay. Bye for now. I think I will not be available, Gopal. Please excuse me. And
sure.
Answer. Okay.
Yeah,
Thank
please go ahead. Thank you.
Thank you. Bye.
Bye.
Thank you very much, sir, for giving valuable insight on nuclear medicine as a physiological and biophysical tool for research and clinical and research investigations. Thank you very much, sir. We have to mention.
Introduce him then, nothing.
Okay.
Okay.
Now it will be
my pleasure.
Now it will be my privilege to invite Dr. Nitin Ashok John, sir, Professor and Head of Physiology, Dean Academics, AIMS Bibinagar, Telangana, as a for next session on clinical nutrition research in physiology, the fundamental basis for improving patient management. Sir has 27 years of teaching experience in medical profession. He has more than 80 research publications in national and international journals. Sir has authored 8 textbooks in physiology and also a textbook of attitude, ethics and communication, and 50 plus scientific articles in magazines and newspapers. Sir is also recipient of Neelam Young Achiever Award, Gold Seal Appreciation by Voice of Prophecy in Pune. And sir is also a member of Association of Physiologists of India, is also a member of Academy of Medical Educators, Cardiff, UK, Royal Society of Public Health, London, UK member of Association of Physiologists of Tamil Nadu. He is also a member of Association of Physiologists of Uttar Pradesh, member of International Dermoscopic Society, member of International Hygiene Society. You, sir.
Good morning, Dr. Nitin. Are you available? Yes, yeah. Dr. Nitin, you can unmute yourself. Yours is muted.
Okay, sir. So first of all, I would like to heartily congratulate you for your appointment as the director of AIMS Patna, and it's really, we all physiologists are very happy about it. And I'm speaking here from AIMS Bibinagar campus, and the only thing is because of the connectivity, I would like my screen to be shared from your end, please. But
yes, we'll do that. We'll be sharing from our side. Your presentation will be from our side. Thank you so much.
Thank you, sir. Thank you.
Yeah. Do it. Done, huh? Voice is not coming. He will not speak. He will not speak. We have to. This is video. Video has to be played.
So can the audio be played from that side, sir?
Yeah, but video should be done, no? No, it is voice is there. I have done it. We have seen. It is there. Voice is there.
Some of the common lifestyle-induced chronic diseases are heart disease.
Go back. It is there. No, it is there from the beginning.
One second.
Just and so start from the beginning. Yeah, yeah. Okay.
Next.
Nutrition is a part of lifestyle medicine intervention. Lifestyle medicine is an evidence-based medicine promoting comprehensive lifestyle changes, especially pertaining to nutrition and dietary planning, physical activity and exercise intervention, stress management for behavioral changes, social interaction support and altered environmental exposure to prevent, effectively manage and reverse the progression of underlying chronic diseases by addressing the cause. Some of the common lifestyle-induced chronic diseases are heart disease, stroke, diabetes, obesity, metabolic syndrome, chronic obstructive pulmonary disease, and some cancer. The pillars of lifestyle medicine include physical activity, nutrition, behavioral changes, sleep, love and sexuality, addiction, stress, and community. In general, we discuss a lot about physical activity, sleep, stress relaxation, behavioral changes, and so on, but diet and nutrition planning and more discussions of nutrition is really what is much more needed when you talk about the lifestyle medicine. Practices in lifestyle medicine. Regular physical activity and incorporation of exercise as a way of life. Exercising for 150 minutes per week, 30 minutes per day for 5 days a week is what is recommended by WHO. Having a good sleep hygiene and having a restful sleep of about 9 to 10 hours per day in adults. Avoidance of smoking and nicotine addiction and reducing alcohol intake. Consuming balanced diet and nutritional modification to manage lifestyle diseases. Techniques for stress management and stress relaxation, visiting nature and forest path at weekends, socializing with family, relative and friend to maintain a social connect. And when you talk about diet, what kind of a diet is very much important for us? A plant-based predominant diet is what is recommended by the nutritionist and clinical medicine people nowadays. The American College of Lifestyle Medicine official statement reveals, for the treatment, reversal and prevention of lifestyle-related chronic diseases, ACML has been recommending eating a predominantly plant-based diet with variety of minimal processed vegetable, fruit, whole grains, legume, nuts.
This is the adult caloric requirement as recommended by the Indian Council of Medical Research, New Delhi. A sedentary man requires around 2,400 calorie consumption per day, and he will require a calorie up to 2,800 for moderate work, and vice versa in a female. The requirement for sedentary work, ladies, is 1,900 kilocalories per day, and for moderate work around 2,200 calories. You also see that the calorie requirement increases with pregnancy and lactation or for carrying out heavy work. Energy yielded from nutrition is what we call nutrients, is something with a basic part of nutrition which is required to be understood. If we consume carbohydrate, what kind of energy or what amount of energy is given by carbohydrate? It is 4 kilocalories per gram. Lipid is 9 kilocalories per gram, protein is 4 kilocalories per gram, and alcohol is 7 grams. The recommended ranges of carbohydrate, protein, and fats, which is recommended for a diet, is at least we should eat 45 to 65% of our diet should be carbohydrate, 10 to 35% should be protein, and 20 to 35% should be fat. Let us understand what are the type of carbohydrates. So these are the simple carbohydrates, complex carbohydrates, and fibers. Simple carbohydrate is present in sugar, all type of fruits, desserts and sweets, and milk products. Complex carbohydrate is present in grains, that particularly rice, bread, and noodles. Starchy vegetables, potato, sweet potato, and yam include a lot of complex carbohydrate. But fiber carbohydrate is present in case of whole grains, nuts, and legumes. The protein requirement by a body per day is around 1 gram, and it's important to eat to prevent any kind of disease. This is present in Greek yogurt, cottage cheeses, mozzarellas, green peas, kidney beans, lentils, and certain poultry. The next important thing is consumption of fat. Consumption of trans fat and saturated fat is found to be harmful, but what is unsaturated fat is found to be beneficial for health. This unsaturated fat is monounsaturated and polyunsaturated. Monounsaturated fat is present in olive oil, canola oil, peanut oil, avocado, and most nuts. Polyunsaturated is present in corn oil, soybean oil, sunflower oil, seeds, cold water fish. Having it in balance or avoiding saturated fats because of its high presence in coconut oil, palm oil, beverages, creamer, condenser milk, or in case of animal fats, butter, ghee, and so on. And trans fat is present in hydrogenated vegetable oil, fast food, cakes, pastries, chocolate, and deep fried food, which vitamin and minerals, which part an important constituent of a diet, is necessary for the growth and development and certain characteristic function of a various part of the body. We require to consume vitamin A, B complexes, and C, which we see in this chart, and as we see, and we'll see the other chart, we see the vitamins and minerals. Vitamin A, as you know, that the daily intake should be around 900 micrograms, and we get it adequately in liver, cod oil, carrot, green leafy vegetables, and so on. But similarly, when you talk about thiamine, it is present more in liver, yeast, egg yolk, cereal and meat, and nut and grains. Riboflavin pyridoxine, as you see, is present in milk, liver, yeast, cheese, green leafy vegetables. And the most important cobalamin is egg, shellfish, poultry, meat, liver, milk, etc. You see the daily intake, and for example, vitamin C is required around 900 milligrams in case of males and 75 milligrams females. It is present more in citrus food, kiwi food, berries, tomatoes. Similarly, consumption of other vitamins like vitamin D, E, calcium, and the trace element calcium, iron, magnesium, and zinc is very much important. I will just go on to the requirement part of the important iron. Like iron is around 800 milligram per day in case of male, and 18 milligram per day in case of female. Magnesium ranges from around 400 milligram, and similarly zinc is for 11 milligram in case of males and 8 milligram in case of female. Green leafy vegetable and whole grain and nuts contain large amount of magnesium, and so the vitamins and minerals play important roles in various functions of our body, and their deficiency can lead to vital disorders which can be concerned in case of human beings. Now, one thing which we should all discuss is regarding the nutrition prescription. It is the type, amount, and frequency of a diet which we should have. We should eat better, but not less. So dietary planning plays an important role in charting of the requirement of those in health and disease. We as a clinical physiologist, and if we are interested to work on nutrition, we should try to consume, we should carry various studies in various disorders, and what is the diet which they are taking in, and what is the modification can be suggested. And should plan for adequate calorie consumption should what be recommended, but what is more is required is planning the diet, and as we see in the subsequent slides, we should take in consideration that they should have a balanced diet which includes the wheat, rice, pulses, fruits, milk, meat products, oils, and sugar, and so on. And what is the amount of protein, fats, and carbohydrate, as we have seen that what is the requirement per day. So the calorie consumption should also be calculated for prescription of a diet. There's a diet plan for a sedentary man with 60. Now, when we go on for the research purpose, we might carry out research in patients of hypertension, patients of metabolic syndrome, diabetes, or other chronic illnesses or nutritional disorders, and we would like to see what best we can done by assessing their physiological function. At the same time, we need to advise them in conjunction or in close association with the clinicians and the nutritionists what kind of a diet will be better for them physiologically. In case of a diabetic diet, goal is to maintain HbA1c at normal level. Refined carbohydrate should be replaced by complex carbohydrate. Increase vegetable and fiber in the diet. Avoid cholesterol-rich food. Avoidance of food with high glycemic index and free. While diet in coronary heart disease include reduction of dietary intake of cholesterol. Avoid food rich in saturated fatty acids such as meat product and some vegetables. Oil like coconut and palm oil should be avoided. Change in lifestyle. Adequate physical exercises, increase dietary intake of fibers, and increase intake of dietary antioxidants is what is recommended. Low cholesterol, lowering regime. While in case of diet and pregnancy and lactation, one should take care of an extra allowances as a requirement. Increases by 300 kilocalories per day during pregnancy and 700 kilocalories during the lactation. Add source of protein, calcium, iron, and other mineral and vitamins to meet the added requirement in food in or while they are lactating. When you talk about the nutritional disorder, the nutrition, obesity, or undernutrition, marasmus and kwashiorkor is a case of concern. Protein energy supplementation and adequate intake of protein is much more required. Usually, marasmic kwashiorkor, in which there are clinical features of both the disorders, just generally seen in India. Marasmus is more common, pure kwashiorkor is sometimes seen. Now, as we go on to see the globally, the people who live about 100, it has been seen the people in Italy or Greece, certain places of Italy, Greece, and various Mediterranean countries have a higher life expectancy, and many of them live over 100. So we wanted to know, or certain studies have been carried out, that how come they are staying so long. So it's a diet which, and here we see that the Mediterranean diet pyramid is suggestive of that every day they have a physical activity, they enjoy meals a lot, they include a lot of vegetables and fruits in their consumption. They are, especially the oil which they cook, they use olive oil to cook their food, and which is found to be one of the healthiest oil, and it prevents various lifestyle diseases in them. They have a lot amount of fish products, and they have a moderate intake of poultry, cheese, and yogurt, and less often the meat and meat they are enjoyed. The wine is taken in moderation, and they have a lot of water, and this is what is the clue for them. And so this Mediterranean diet reduces saturated fatty intake, reduces amino acid intake, microbe data derived metabolites are there is introphytochemical intake, and reduced calorie intake, which leading to decreased growth factors, decreased nutrition sensing pathway, increased resistance to stress, decrease in inflammation, increase in immune response, decrease oxidative stress, and infuse sensitivity. The sense, what are the other thing which is important when you recommend is the brain food which we should require for adults healthy, especially in case of children: coconut oil, green vegetable, avocados, broccoli, pure chocolates, beets, celery, nuts, and berries have a good amount rich brain food. As we try to see certain of the research, Hayos et al. Has pointed out that dietary patterns such as Mediterranean style dietary approaches to drop hypertension, low carbohydrate and low fat diet can ameliorate insulin resistance and metabolic syndrome. Long-term adherence to healthy lifestyle is the key in assuring that individuals significantly reduce the risk of cardiovascular disease and diabetes. Saslow et al. Has found out in their study that a very low carbohydrate diet coupled with skills to promote behavioral changes improve glycemic control in type 2 diabetes while allowing decrease in diabetic medication. Ozo et al. Has pointed out that low glycemic index and low carbohydrate diets effective management of type 2 diabetes mellitus, but especially the role of unsaturated fatty acid, vitamin and bioactive compounds in chronic disease management has found to be helpful. One should also look toward the glycemic index value of the food and try to have a food with low glycemic index, as you see in vegetable like cucumber, lettuce, pepper, spinach, etc., or in case of grains in sweet potato, white rice, wild rice, and so on. So the dash food, especially preventing in the face of hypertension, and especially all of us should try to practice it and practice in a daily life also. Eat lot of vegetables, lot of fruits, whole grains, fat-free or low-fatty diet. Fish and poultry products encourage beans, nuts, and seeds. And vegetable oil should be used and should be consumed. Simply avoid fatty meats, full fat dairy, sugar sweetened beverages, sweets and sodium intake. Have a low intake for sweets and pastries and all those. Go less amount on them, and definitely you have a. So take home messages: eating healthy, clean, and nutrient-rich food fills your body with energy, nutrients, and antioxidants. Imagine yourself smiling back at you, saying thanks for the longevity and healthy life which they get in return. Thank you all. Thank you so much. We here at All Indian Institute of Medical Sciences, BB Nagar, Hyderabad, are also on the way of starting a lifestyle intervention for our patients, and we would go in a longer way to arrange various conference workshops in the days to come. Thank you so much.
Yeah. Thank you, Professor Nitin. It was a wonderful talk, and you have given your speech within the stipulated time. Actually, this is a big talk, but you have made it really so crisp, precise, and so meaningful. Thank you.
Yes, sir.
Thank you so much. Thank you so much. Yeah.
Thank you, sir. Thank you so much, sir.
Thank you very much, sir, for sharing your deep knowledge with us about clinical nutrition in physiology. Thank you very much, sir.
Thank you. Thank you, madam.
Leader is one who knows the way, goes the way, and shows the way. So may I request such a great leader, Dr. G.K. Pal, sir, Professor Senior Scale of Physiology, JIPMA, Faculty in charge of ASITA, JIPMA, and Dean and Faculty of Medicine, Pondicherry University, to guide us for the next session on how do I become a good clinical physiologist while working in a medical institute. He is an excellent leader. He does not require an introduction. Therefore, I request sir to deliver a speech without any further ado. We welcome you, sir. PPT of speakers. அது ஷேர் பண்ணணும் இல்ல அது ஓபன் பண்ணாதான் அதுக்கப்புறம் ஷேர் இல்ல அதை ஓபன் பண்ணிக்கலாம்
Okay, I'll be using this one.
This one.
Oh. I can start. Yeah. A very good morning, all of you. And yeah, good afternoon. It is not moving. Yeah. Can you close this part? That bar may be taking so much. My scheme of presentation will be what is clinical physiology, who is a clinical physiologist, what is clinical physiology research, and how do we design and start a clinical research in physiology, and what is the importance of a clinical research. The clinical physiology is the application of knowledge of body functions in patient management and research. Physiology is not only the study of body functions and regulation of functions. Physiology is an integral part of medicine and medical curriculum, and physiology is therefore not limited to first MBBS teaching as designed by earlier MCI and now by NMC. Though NMC has made a lot of changes to make our subject clinical applied, but really I do not see really the subject is really pro-clinical. It is just like, I will say it is just a IWAS, nothing much is there actually to make it really clinical physiology, which should be clinically based. The physiology is more attributed to learning when actually students go to pharmacology, pathology, general medicine, anesthesiology, and all clinical subjects, and also cardiology, neurology. They see actually the application of physiology in clinical medicine, and therefore the importance of physiology lies in the understanding the pathophysiology of disease processes and appreciating the physiological management of diseases. Therefore, the primary task of a physiology teacher, that is we, to make the students appreciate the importance of physiology in learning various aspects of medicines, especially the pathophysiology and physiological basis of management of diseases. A student, therefore, finally should realize that it is impossible for him to become a physician without knowing the basics of physiology, which I say the clinical physiology. The role of physiologists in clinical investigations. Physiology department must provide, I say must, not should, it must provide the clinical lessons, such as the pulmonary function tests. I believe that it is being done in all the institutes. Electro diagnostic procedures, though recently, we have started in many institutes, but earlier it was not there in many places. But I wish actually that this should be, people have started doing, they do it part of the research, they do part of their, the training, teaching. But what I am telling actually, it should be the part of clinical investigation. That means patients from the Department of Medicine, from neurology, they should be referred to physiology, electrodiagnostic laboratory for investigations like nerve conduction, EMG, Evoke Potential, and the report of physiology department should be part of the clinical management. Cardiovascular function tests, of course, we have started in many places, autonomic function tests. But again, I would like to say, we have started, but it has not been established as a clinical investigation for patient management. That is why what I would like to emphasize that it must be part of the clinical investigation in the institute for the hospital patients, hormone assays on hospital patients. So a report from physiology laboratory should contribute to the diagnosis of the disease and assess the course and prognosis of the disease. And proposal for such facilities should be given to the institute management. It is our responsibility. It is actually, how we put it and how we take it and how we do it actually. So we have to give the, the proposals to the management, and we have to get the approval, and we have to start doing it. Physiologists should be trained because of the clinical investigation the investigations that are to be done and which is now should be part of the patient management. And once the investigation becomes part of the patient management, the report should be thorough and should be very precise. Therefore, the physiologist should be first trained in conducting clinical investigations, analyzing the report of the patient investigations, data interpretation in proper clinical perspective, clinical follow-up. This is somehow, should be extra. We must do this. After we give an report, investigation report, we should follow up with our friends in the clinical department to see actually with the clinicians for the disease diagnosis. That means how much our report has really contributed, how much they have even interpreted our report for their diagnosis and the patient's condition, progress, and of course the management. So we should actually follow up. Then only the interaction between the clinicians and the physiologists become more close and more effective. The systematic workshops should be done for this actually. It is our now responsibility to see that we must conduct workshops regularly, especially at the centers of higher learnings of, I or even the better medical institutes for making all these, how to investigate, how to analyze a report and how to give a report for the clinicians to have the diagnosis. In fact, at JIPMER, we conduct this workshop annually, but for the COVID for last 2 years, we have not done and we will be restarting soon. In patient management, the physiologist should be integral part of the patient management. Not only that we give the report for the patient investigation report and for diagnosis of the disease, we should be part of the patient management. Physiology professor should therefore be adjunct or additional professor in a clinical department of his choice, as it is there in most of the developed countries. Somehow the system in our country has not been tuned in this line from the beginning, and there is no mindset and there is no opening for this. Therefore, now the time has come, we must give representation to NMC for this actually. We must give the representation to before this. Yeah. So we should give representation to NMC of such proposals to involve physiologists in the patient management as a faculty, like a consultant faculty or a guest faculty or kind of adjunct faculty. But not only that we give a proposal, we must be ready to take up the extra responsibility. Once you become part of the patient management, this duty will be something extra, something more, in addition to our duties and responsibilities in the department. So we must be ready also to take up such extra responsibility. This will provide the ground for establishing the clinical physiology. Then in medical research, as we know, research is an essential and integral part of medical education, and therefore importance of physiology lies in its contribution to medical research. Progress in medicine, directly or indirectly, is linked to the outcomes in physiology, especially in clinical physiology. To be mentioned here, most of the Nobel Prizes in last few years, I'm not telling the initial years, if we see the last few decades, most of the Nobel Prizes have gone to this works done in medicine. People, if they see from outside, they'll think that it is not physiology, but actually if you go into the details, you'll see these are pure clinical physiology work. And all actually, everything, all, you see last 5-6 years, these are pure clinical physiology research. Therefore, Nobel Prize, which was earlier designated as Nobel Prize in Physiology, now it has been redesignated as Nobel Prize in Physiology and Medicine, to say that medicine, which is the clinical physiology, is actually more important, and that is what actually is now accepted by everybody. So the glory of physiology lies in its research contribution, which we should now rebuild and develop much further. All physiology departments should have research laboratories, especially for conducting clinical based studies. nowadays many, institutes are there. They are just end with the terminology, research institute. All the name will be there, then ends with research institute. But by naming a college just research institute does not do it. There should be really the research facility, especially in physiology department, because physiology department is the core research subject. And for this to happen, the MD students in all the physiology departments, they must have adequate exposure to clinical training and research during their course curriculum. Then physiology in medical research, emphasis should be on clinical research. Clinicians should be part of the program. Unless they are part of the program, the clinical research will be a failure, but especially if it is conducted by the physiologists. Clinicians should be involved in designing the research protocol from the beginning, from the designing itself, designing the protocol, then during the recruitment, screening of the patients, then conducting the investigations. Of course, investigations will be done by us, but they should also can be part of this. But most important, the data interpretation, which is actually to be little interpreted according to the disease, severity, disease progression, or the disease variants, where we need their help, and they must be part of the integral part of the program. This gives the opportunity for the physiologists to interact more closely with the physicians, and then it becomes more bonding between the physicians and physiologists. Not only that, once you have a clinician in your publication and it is a clinical based research, the acceptability of the paper also becomes more. The acceptability of the paper for publication in a good journal. Not only that, when a clinician is part of it, also the extramural funding agencies, they give more emphasis on the work, on the proposal, and to get funding also becomes much more easier. If we are capable of impressing clinicians, the role of physiologists in medicine and medical research. The main problem in many institutes, physicians do not, I'm telling you the truth, the physicians, they do not really consider physiologists are that competent or that good actually to be part of their program. So it is our, responsibility or some kind of, our own way of dealing to develop a system where actually we can impress them. So we have to impress them that the physiologists also can play a role in medicine and medical research. They will not only appreciate the relevance of physiology and medical science once they are impressed upon us, by us. Also, they will understand the value of involvement of physiologists in patient management, which is actually part of the program in all the developed countries. Especially importance of physiologists in clinical research, for which they don't have time and interest. Most of the good clinicians, they are always busy with the patient investigation, diagnosis, managements. Actually, they don't have time for research, they don't have time for publications. But now, all have to publish, whether you are in clinical department or non-clinical department. And they fail to publish because they don't do research. So if you go with a proposal that I want to do a research, why don't you become part of this thing, and you get a publication, and they are convinced that yes, this is a good research and it has a lot of clinical application and they can contribute, they take more interest, and then they become part of the program. Designing a clinical research. India is a huge country, large population, and we have one, I'll say it is a blessing in disguise for medical researcher that we have large uneducated mass of patients. So when you go and approach a patient, you can easily convince them, and you can make them part of your study sample. You can recruit them and into your study as a subject or a patient, because they are not that much educated. In all developed countries, to recruit people, whether normal healthy subject or patients in the study, you really struggle. It does not happen like that. So large sample size is not a problem, but I'm telling you, a larger sample size is a must if you are doing a clinical research. The main problem with us in India, especially for the physiologists, we take up a MD students work, MSc students work, even in PhD work, 50 to 100 sample size, do the case control study, compare something, than just publish in a non-indexed journal or a basic PubMed indexed journal. And there is our problem. And that is how our works are not appreciated. There must be a large sample size in a clinical research. Start with a clinical research project in collaboration with biochemistry, medicine, cardiology, or whatever. I mean, depending on what is your topic or the protocol. Just for example, I have put one here. Let us say the uric acid is a marker of inflammation, cardiovascular dysfunction, and glycemic control in pre-diabetes in Indian population. If this study you take up, then you must also go into this, the male-female difference. You should also go into it, the gender difference, the age difference in younger population. I mean, the pre-diabetes, which is nowadays so common in younger population. So in the, I mean, from let us say 25 to 50, then 50 to 70 or above. So you can do, I mean, intergroup analysis only when you have a larger sample size. So that is why I have put here minimum 500. Then such a proposal you can submit to ICMR for funding, and ICMR has come up with a lot of attractive proposal to be funded. And initially, don't be more ambitious and put up a proposal like 25-30 lakhs. Just give us a small proposal, maybe between 5 to 10 lakhs. You are likely to get. I'm telling you, especially this yoga-based study. A lot of yoga proposal fundings have come up in Satyam, in DST, DBT, even ICMR. Just put up a proposal. This intervention, yoga in pre-diabetes, diabetes, hypertension, you'll get a good, but there should be some novelty. Then out of this, the proposal, which is about 10 lakhs or less, just publish 1 or 2 publications and must be in PubMed index journal. Then with that, submit for a bigger proposal to DST, DBT, 50 lakhs or above, and then you become this, the field is yours. Clinical research, it must be multidisciplinary. It should not be only the physiology people doing, studying something like a normal healthy subject, take something, I mean, effect of obesity, effect of gender, all these things. It must be multidisciplinary. I mean, it should be involving the medicine department, endocrinology department, biochemistry department. And I'll tell you, that is what I had today invited my friend Prashant to speak on this, nuclear medicine. The contribution of nuclear medicine or the basis of physiology research based on nuclear medicine. A lot of things can be done and quality work. I'll come to that little later. And it must be multicentric. If possible, just do it in your college. You do it at different places because there are a lot of regional variations. There are a lot of environmental variations. There are a lot of many, I mean, the India is such a vast country. The region to region, so much of differences. Make it multicentric, make it multidisciplinary, then your work is more appreciated. Should be ideally a clinical study and interventional study. There should be some kind of intervention. Let it be exercise, let it be nutrition based, let it be yoga, let it be any kind of lifestyle. And interventional study is nowadays, especially lifestyle intervention, is highly appreciated. And again, I'm telling you, if your proposal is a randomized control trial or randomized control clinical trial, RCT, then your work is really of strength, quality, and this becomes your asset actually for publication. If you do some case control study or you do some kind of, I mean, just cohort study, then you never get publication in good journal. Should have larger sample size. I have been emphasizing this. It's such a big country. We have huge population having diabetes, hypertension, heart disease, asthma, a lot of things. Any disease you take up, it should be more than 500 sample size. That is what I suggest. And should have more investigations and parameters. It should not be just the samples taken from, I mean, the parameters available in your department, and then you just take some blood pressure, then some maybe HRV, and maximum you take some biochemical parameter and do a study. That does not work. I mean, for a better publication, you must have many investigations, more investigations, and quality investigations. I'm telling you, that is why I had invited Prashant to make a presentation. I thought that people will definitely, I mean, appreciate how the nuclear medicine can contribute to a quality clinical research in physiology. For example, I'm doing a yoga project. My yoga project involves the just breathing exercises. How this breathing can change the flow of blood in different areas of the brain, in the cellular metabolism inside the cell, I mean inside the brain. in the tissues, in the how it can also finally lead to alteration in the proteins in the the cells of the brain. That is what is the quality research, and that is how the people are publishing in USA, Germany, and we are lagging behind. And things are available in the institute. I'm telling you, nowadays all institutes have Department of Radiology. In all institutes there is PET scan, CT scan, everything is available, but we don't understand the utility of it in physiology research, and we don't involve them, and that is how we are isolated, and we just think what can be done maximum with the biochemistry, physiology, or maybe a little bit of pathology, microbiology, and just we do something. There must be qualitative, and more parameters for a clinical research. And as I have told you already, this there should be the clinicians should be part of this clinical research project. I'll just give an example how actually there are a lot of this thing, but I thought that I'll pick up one. In IJCP one paper had published. This is not now actually, some few years before. I have changed the name, and maybe the institute name is not changed. So you can see here, the title of the paper was Assessment of Cardiovascular Functions in Obesity. And this is, I mean, it was actually presented to the journal as a clinical research. And the parameters studied: age, anthropometric parameters, obesity indices, heart rate, blood pressure, echo parameters, and correlation of ejection fraction with BMI, skin full thickness. And it's a good paper. It's a really good paper. I mean, the way they have designed, they have done, it was really a good paper. But see here, there is nobody, I mean, co-author or co-investigator from medicine or cardiology. And how as a physiologist, you interpret the echo parameter. You can say that I have been trained, I know so much, but I'm telling you, when you are submitting a paper for a good journal, they'll insist actually that you must have, when echo parameter is there, you are correlating the ejection fraction with various biochemical, physiological parameters. If you have somebody from even medicine, then your acceptability and also the authenticity of the data is more, I'm telling you. Not only that, in such this thing, even if you submit to a higher journal, they insist even a good biostatistics expert should be a co-author in your publication. In fact, recently we had submitted one paper to scientific report where actually the impact factor 4.386. It was a very good paper, well done. Even from same one faculty was there, who was actually a statistical expert. But still, at the end, everything after 2 revisions, the editor-in-chief insisted, Dr. Pal, I'll be very happy to address your sample size calculation. Something is missing. You take the help of your institute biostatistician. This PSM person will not be adequate for this. And I, honestly speaking, I contacted one of our best, professor of biostatistics, and the way he addressed, the way he gave his note, it was wonderful, and it was a learning for me. So what I'm telling you, we must be open to involve clinicians for interpretation of the clinical data, statisticians for how you do the statistics. Then only your clinical, especially if it is clinical research, it becomes more effective and really becomes a excellent paper. A medical student, nowadays actually there's some people in this last NEET exam, PG NEET exam, in spite of even decreasing the percentile 50, the eligibility from 50th percentile to 30th percentile, still many, the MD seats were vacant because there are no takers for MD in physiology, in anatomy, and in non-clinical subjects, because there is no appreciation. They don't understand actually the utility of this in clinical medicine, or there is no scope. We have failed to impress upon our younger generation that our subject is really so vibrant. It has a lot of scope and they can do a lot. A medical student appreciates physiology better when he realizes the involvement of physiologist in clinical medicine and research. And therefore, the goal should be making physiology more applied and clinical. More participation of physiologists should be in clinical research and management. This is the era of genomics, metabolomics, and proteomics. Genomic, metabolomic, and proteomic parameters should be there in the clinical research. You may be thinking when I'm telling clinical research, it is only the clinical, I mean the patient-based. It is only you take patients, a disease condition, you study the parameters available with us, maybe basic or little more than that. But I'm telling you, if we have, in addition to the clinical design, genomics, metabolomics, and proteomic investigations, which has to be really finally at the end to be correlated with these clinical parameters, then only the work becomes more meaningful, more having more weightage and more acceptable for publication in good journals. Otherwise, again, we just land up in publishing in non-indexed journal or maybe just basic PubMed indexed journal. If you want to publish, let us say in the pre-hypertension, pre-diabetes, if you have genomic parameters, you have proteomic parameters, and high level of metabolic parameters, the quality of research increases and you get good publication. Then the question you will ask me, how do you do it? पाल साहब आपका जिपमर में तो बहुत कुछ है, एम्स में बहुत कुछ है, डॉक्टर के दीपक ने ऐसे स्पीच देते हैं, आप भी ऐसे स्पीच दे रहे हैं. So you all speak like this because you are in INI. What I'm telling you recently is the Dean of Faculty of Medicine. I took this inspection for 2-3 medical. Usually I don't go for inspection, but I was the chairman of the inspecting team for 3 medical colleges. I inspected. I went there. They have everything in the institute. They are really good institutes. Nowadays, every institute has minimum RT-PCR machine. They have minimum all these metabolomics estimations. They have everything, autoanalyzer, advanced autoanalyzer, even they have advanced histopathology techniques available in the institute. But we don't realize that, and we don't involve these parameters for our research. So what is to be done actually? Maybe a central research facilities can be opened in the institute so that you avail all these facilities in your central facility, or just keep these faculty, the colleagues from these departments as your co-author, then you get everything done. So it is actually how you have to just a little bit design it. Things are available in all institute. It is not that the things should be there only in physiology department, then you do it. So it has to be just little bit integrated, and then your research becomes so good. That is why I always say, that is why I had today brought my good friend Prashant into our talk, because physiology is there everywhere. Nuclear medicine is full of physiology, and therefore physiologists are privileged to have a collaborative medical research in the field of clinical physiology. Importance of physiology as a clinical subject in medical science depends on our own image as a teacher and researcher among the medical fraternity in the institute. How you have projected yourself and how you have built yourself among the students and among the staff of the institute, that yes, here is a laboratory, here is a group that they are capable of doing, and our ability to influence our colleagues in the clinical department to recognize our skill and share our skill, and our ability to convince administration our due in clinical medicine and research. This is the beginning. Once this is done, we take this to the higher level that I'm telling you, to NMC and other the policy making bodies of the institute. Now I hope that after assuming this new responsibility, I'll be in a better position to take it and get it approved. We should see, I'm telling you this actually, we have a habit of comparing ourselves with somehow these, the non-clinicians. When I say non-clinicians, I mean, it should not be misread or misinterpreted. In last maybe 1 year, there is so much of comparison between the medical physiologists, non-medical physiologists, lot of confusion I see in the group. We speak so much, they have gone to court against us. Our people have also directly or indirectly in different fora, they are discussing all these things. But I'll tell you, so far I am concerned. Maybe this is my personal opinion, don't take it as the General Secretary of SOP. I never compare myself with any group. I know that who am I? I mean, don't think that I'm Dr. G.K. Pal speaking. I am a physiologist, a clinical physiologist who is speaking. I know what is my basic qualification. I am MBBS. I have done MD, and I have done a lot of work in clinical physiology. I do not wish really to myself to compare with the non-medical people. For them, the degree is different. Their, the training is different. I do not wish actually that I should be compared with them. I don't have that they're inferior to me. Please don't. That is why I said please don't misread. They are a different group and they have a different scope and the perspective. What I'm telling, this is a habit for us to just compare with them and we become so happy. We say we are great. But I'm telling you, our comparison is actually the clinicians. And I have gone through a lot of, I have attended meetings. I have gone through a lot of experiences in my life. I have seen how clinicians, they treat us, they look at us, they see us really inferior. And maybe we have not come up and we are also responsible for that. I wish to compare myself with them because they are MD degree, I have also MD degree. They have also, they are in the medical college as a faculty. I'm also there as a medical college as a faculty. And we have a lot of things we have done in clinical medicine. But still, there's a gap. And that gap has to be filled. And that is why the integration has to happen. And that is how the clinical physiology has to develop. And this is another, a topic which I thought I should introduce here in this discussion. To do any research, and especially clinical research, you must take your head of the department into confidence. Your HOD should be there. I don't say that in your protocol, HOD should be a co-guide or the co-investigator. I don't say that. You just see to it that your HOD, you have the blessings of your head of the department. And also you see to it that, and that is why I said if possible, you have the blessings of your institute head. Then why I'm telling you this, your HOD or even the institute head will link you to the other departments, which even you may fail to do. Will link you to other laboratories in your institute or even in the local, your localities. If other institutes are there having such facilities, they can really link you. And never, I'm telling you, even if you have differences with your head of the department, never complain against him or her to the head of the institute. I'm telling you, if especially don't give in writing, and this will, ruin your, I'm telling the research career. And you must take your heads, the head of the department, who is a senior, keep a good relation, and if possible, head of the institute into confidence. Your clinical research will be a, pleasure to do. Most important is we must live with this conviction and the pride that we are physiologists, and now we are clinical physiologists. I always therefore tell my students, and it is there in my books, all physiologists are good physicians, and all good physicians are physiologists. Thank you so much.
Thank you, sir, for such an informative and a fruitful lecture on the highlighting the role of physiologist in clinical research and teaching, and also training, and also you have also the ways and means by which you achieve this. Thank you very much for your very informative lecture, sir.
Thank you very much, sir. Now it's time to facilitate our guest of honor, Dr. G.K. Pal, sir, on his for leaving from JIPMA and on his appointment as Executive Director to AIIMS Patna. I would like to invite all faculty members of Department of Physiology on behalf of Department of Physiology to facilitate our guest of honor with a shawl and photo citation.
Yes, now we have to hand over to him. He has to speak few words. Yeah. After, yeah, sure.
Congratulations and best wishes. I will just tell few words before, and you have done a wonderful job, and you are our hero. So, all departments.
You can say this is a citation from.
Yeah. This is a photo citation from Department of Physiology. On behalf of Department of Physiology, my heartiest congratulations for your new responsibility as Executive Director of AIIMS Patna. Under your leadership, we know it's going to flourish. And thank you so much for all these years, for your guidance, for your support, for mentoring us for all through your career, sir. Thank you so much, sir.
Speaker is there.
Good afternoon to all of you, our respected Dr. G.K. Pal Sahab, and now Director AIIMS Patna, and other dear and respected other physiologists, those who have presented, and very insightful and wonderful presentation. And I am very much delighted and happy with your presentations and Dr. G.K. Pal Sahab's presentation. 1 minute, 2-3 minutes I will speak. Dr. G.K. Pal Sahab's contributions to the department and to the physiology. Yes, everybody knows, and he is a superstar of our physiologist. That is why he is occupying so highest position. And my personal interaction, he is a good friend of mine since beginning, and he's contributed a lot to me as physiologist and as well as my personal and family life contributions. He has been contributed a lot to the department. As beginning, he was very senior professor, and right from when Dr. Madan Mohan was there, our new building was made, and because of his good vision, and he could think forward in future. So the infrastructure of our department is can be compared with any of the international institute of physiology, even AIIMS Delhi. This is not only infrastructure, he has many contributions preparing the very high-end equipments, and many of the at par with the institute of national importance, and it is better than any of crores of instrument. He, because of his guts, cooperation, and well communication with the higher ups, he has been a very good physiologist. In terms, you already know, he has more than around 20 awards and 220 original research papers and 300 citations and H index 29. He might have been told this, but because of this only, he is now our hero and occupying so higher post. And he has contributed a lot for the establishing the SOP and organizing SOP from senior physiologists from all over the world. All over the India. Also, many physiologists, they from internationally, they appreciate our organization. Today, our most of the speaker spoke on very pertinent and wonderful topics, which can be say for example, say Dr. Latika Mohan and Dr. Nutin Johan, Dr. this Burma Saab, and Mrinal Pathak, and all of you, our physiology professor, Dr. Prabhati, Dr. Vel Kumari, and Dr. Dhanlakshmi, you all spoke to these topics which really belong to physiology, and they can become topics of your super specialty. You can contribute a lot. No clinical clinicians have time or do these things, and we can be super specialist. In fact, when I was HOD, I given proposal for DM clinical physiology, and also PDF in neurophysiology, and the fellowships in IONM. When Dr. Basant was there, she was doing this IONM And so we wanted to these three courses, which are really super specialist. Nobody else can do. Only physiologists can do. And they and many subjects, like you have spoken on nutrition, you have spoken on electrophysiology, and you have spoken on high altitude physiology. They all need physiologists, and they are really become a clinical physiologist. And so with these words, I congratulate Dr. G.K. Pal Saab and thank him for all the contributions. He has really made a difference in physiology. And I request all the physiologists, those who are at the higher levels, higher status, they can influence our higher ups. So to take the physiology to the at higher level, at the semi-clinical or clinical level. So our younger generation, they are very hesitate to come physiology. Physiology taken is at the last choice. Even after the third, they hesitate. So at last, nothing is available. They come to the physiology. So they come by chance because they have nothing else. Our Dr. G.K. Pal Saab came for physiology by choice. So the people should come by choice if we make it attractive. And attractive, how we can make, if in your field you can do this super specialty research. This super specialty research, neurophysiology, electrophysiology. Now, cardiac electrophysiology, which is a very specialized branch, but physiologist has to be involved. So with these few words, I want all of higher senior professors can influence the bodies, especially Dr. G.K. Pal Saab. Now he has become a very high status person. He will be involved in very high level committees. He can push forward our physiology to make it to go as semi-clinical or clinical, and to get all these super specialty along with physiology. Like DM I wanted to start, but I couldn't. Fellowship I wanted, I couldn't. PADF. So all these things I request all the senior physiologists, Dr. G.K. Pal Saab, to push for, physiology to the forward level. And I wish him all the best for his future endeavors. He should bring the AIMS Patna at par with the AIMS Delhi and JIPMER, and even better than. Before I finish, I just say, because physiology is not being taken, and we think what is the future of physiology. So they, from one serial, Hindi serial was there in olden days, in the Doordarshan. Which song was there? मैं रहूं न रहूं ये देश रहना चाहिए, हम रहें न रहें ये देश रहना चाहिए, मैं रहूं न रहूं फिजियोलॉजी रहना चाहिए, हम रहें न रहें फिजियोलॉजी रहना चाहिए, मैं रहूं न रहूं फिजियोलॉजी की विजय चाहिए, और हम रहें न रहें फिजियोलॉजी की विजय चाहिए. This word I hope you will contribute and push physiology forward. I once again thank and wish Dr. G.K. Pal Saab very best. Thank you, sir. Thank you all, one and all.
Prabhu, you can come here.
Computer can declare the next vote of thanks.
Where is Kavita? Come here and speak.
You have to declare. Invite.
No, first you. Wait, let us finish.
1 minute. They will declare.
Thank you very much, sir. Now I would like to invite Dr. Additional Professor of Physiology, JIPMER, Puducherry, for delivering vote of thanks.
So, good afternoon, all of you. So, on behalf of Department of Physiology, JIPMER, and the organizing team of this webinar, I am happy to be here to express my vote of thanks. First of all, I would like to thank Director and Dean Academic of JIPMER, for giving permission to conduct this webinar in this studio. I also thank Dr. Ravikumar Chittaria, Head of the Telemedicine Department, and the entire team of Telemedicine Department and the studio for helping us to organize this webinar. I thank the Office Bearers of SOP for permitting us to conduct this webinar under the banner of SOP. And also, I thank the speakers of the day, Dr. Rajesh Katare, Director, Division of Cardiovascular Physiology, School of Biomedical Sciences, University of Otago, New Zealand, Dr. Pravati Pal, Professor of Physiology, JIPMER, Puducherry, Dr. Velkumari, Professor Hent, Department of Physiology, JIPMER, Puducherry, Dr. Dhanlakshmi, Additional Professor, Department of Physiology, JIPMER, Puducherry, Dr. Latika Mogan, Professor and Head, Department of Physiology, AIMS, Rishikesh, Dr. Mrinal Phatak, Professor and Head, Department of Physiology, AIMS, Nagpur, Dr. Deshpande, Emeritus Professor of Physiology, Apollo Institute of Medical Sciences, Chittoor, Andhra Pradesh, Dr. Prashant Pradhan, Professor of Nuclear Medicine, SGPGI, Lucknow, and Dr. Nitin Ashok John, Professor and Head, Department of Physiology, AIMS, BB Nagar, and Dr. G.K. Pal, Professor Senior Scale, JIPMER, Dean, Faculty of Medicine, Pondicherry University. So all the speakers, thank you very much for delivering the shared knowledge. And I thank the Physiology Department faculty, senior residents and junior resident, PhD students, MSc students, staff of Department of Physiology, they involved in the organizing this program. And special thanks to Mrs. Bharati Balakumaran, Mrs. Muhammad Ishaq, Dr. Savandar Rajan, Dr. Praveen Prakash, and Ms. Renuka Sundari. So they arranged this program very short notice. Finally, I thank all the participants, those who registered and attended this event and make this event grand success.
More than 500 participants.
More than 500 participants, they have registered and attended this program. Thank you very much, all of you, all the participants. Thank you very much.
Yeah. Thank you so much for all your love, your affection, your blessings for me, for your good wishes. I am getting relieved from JIPMER today afternoon. I'm traveling to Patna tonight. I'll be reaching there tomorrow morning, and I'm taking over the AIMS Patna director tomorrow, maybe at 10:30 to 11. And my next program will be from Patna. And again, I'll keep it, a little secret what will be the program of SOP from AIMS Patna. I'm sure all of you will enjoy the next program. And wish you all the very best. And again, I convey on behalf of the SOP headquarters and the Department of Physiology for all the your interest, enthusiasm, and your participation in today's program. I see still there are so many participants waiting to see and how things are happening even till end. It is really actually it gives me the real spirit and the real the motivation that as physiologists we are so much united and we can do so much. Thank you all.
Sir,
yes. Anybody,
sir, can I say something, sir?
Sure. I mean, now can speak. Yeah, can speak. Please.
Dr. Sabita from GMC Kathua, sir. And sir, especially, we are a big fan of course, sir, and all the physiologists of especially JIPMER and SOPI, and it feels so emotional while, sir, seeing all this, and you have really made us proud, sir. And we really miss that physical mode conferences now, sir, and really so proud to see that, sir. And Pravati ma'am, Pelakumari ma'am, and Dr. Gaur and all the team, and of course, sir, it has been a wonderful experience, sir. And really, once again, congratulations, sir. Congratulations. You are a motivational
person for so much of us, sir. So really, congratulations once again, sir. Thank you so much, and all the best, sir. All the best. Sir.
Yeah, Dr. Bandana, you wanted to say, yeah. Dr. Bandana, please.
Very good afternoon, sir, and team JIPMER. Very good afternoon, sir.
Good afternoon.
Yes. Hearty congratulations to you, sir. Hearty congratulations, and wish you all the very best for your future endeavors, sir. We really, we are truly inspired by your hard work, dedication, and we are really, we admire your simplicity, sir. That is what, like, we have seen all the messages in different physiology groups and SOP group. I really admire, sir, being so much busy and being so much into the subject. You see to it that you personally thank each and everyone. I like your attitude towards that, sir. It's really truly admiring and inspiring. Thank you very much for it, sir. We wish to seek your guidance, your precious guidance and your blessings all throughout. And we really promise for working hard towards the upliftment of all the physiologists of India. Thank you so much, sir. And last but not least, I wish to thank all the eminent speakers of today's excellent webinars. And it was altogether an academic feast, sir, covering all different topics and giving us a newer insight. Thank you so much, sir, once again.
Thank you, Bandana. Thank you so much. In fact, this program was organized in such a short notice. I never thought that we'll be able to do so much. It was just organized in 5 days' time. But of course, because of our contact and because of our, even the resource persons availability and the facilities provided by JIPMER, we could do it really so well. I'm really so happy that it became really a wonderful program. Thank you. Thank you so much.
Any more questions? Dean
Dr. Yeah, Dr. Din Prakash Ranjan. Yeah, please.
Sir, congratulations on becoming director of AIMS, sir. Sir, I think he will be best person for the AIMS director, and we wish you very much for your future, sir. Thank you very much, sir.
Thank you. Dr. Saab, आप पटना का है क्या?
Yes, sir. We are from there only.
From your accent, I could realize, because in last few days, I have got so many phone calls. The way you speak. Now I have also started speaking like that.
I will come to Patna to meet you, sir.
Sure. So nice. Thank you. Thank you so much.
Yeah. Thank you very much, sir. And wish you best luck.
Yeah, thank you.
Some more participants we are not able to see.
We are not able to see actually all the participants asking to maybe requesting. Yeah. Anybody else wish to speak? Otherwise, we can conclude.
And hands up should come here.
That arrow I'll click.
Any hands up?
Hello. Yes. Yeah. Hasmukh. Hasmukh, I think Hasmukh is speaking. Yes, Hasmukh.
Yes. Yes, sir.
Yeah, you're always, the handsome hero of SOP.
First of all, good afternoon to all, and I congratulate all JIPMER team for organizing such wonderful event, and many congratulations to Dr. G.K. Pal sir for being selection as a executive director of AIMS Patna. It is really great moment for all of us. And one thing I want to share to all of you, that Dr. G.K. Pal sir has lots of publication in so many reputed journals. If you see the American Journal of Cardiology, BMJ, Frontier, so many journals. When I check their publication from cardiovascular, yoga, meditation, HRV, so we are very privileged to have dignitaries like Dr. G.K. Pal sir, and he is the General Secretary of SOP, Association of Physiologists of India, and he is leading the organization since last few years and providing great leadership and supporting from the sir. So again, thank you, sir, for your future job at AIMS Patna. Thank you.
Thank you, Hasmukh. Thank you so much. And we'll meet at Patna very soon. And as a few of our participants, I think Dr. Sabita Yogaraj was telling, we are missing the physical conference. For the physical conference, for the physical conference, we are going to meet in Nagpur, October 14, 15, 16. I before that, if possible, we'll do at AIIMS Patna, but we are going to organize a beautiful program at AIIMS Patna very soon. And that I do not want to tell you now. It will happen very soon. I mean, people cannot even imagine how things can happen. And I hope that that also becomes a good program. Thank you. Thank you, Dr. Hasmukh. You are always with us, and you are also there in the forefront of the association. And I thank you for all your contributions. You are the person who has conducted 2 SOP conferences, and I have given 10 out of 10 for the conferences you have conducted. And thank you so much, Hasmukh.
Thank you, sir.
Yeah, so I think now we have one photo session. So what we can do now, you will not be, we won't be take your photos, and physically, but I will request all of you to put your video on, and then I will take a picture of this. We have a bigger screen, and please put your video on so that we can take a picture from the screen. We have a larger screen actually, so we'll be seeing you. अरे सतीश दीपांकर, अरे तुम इधर हो, कुछ भी नहीं बोल रहे हो क्या?
Hello, sir.
हाँ.
Hello, sir. Am I audible?
Yeah, you are very much audible.
Yes, sir. Here it is a lot of disturbances. I came out, just now came out.
Yes,
and just now we came to have a lunch in the GMT Ramnapuram campus. And
I think already you are in the lunch lawn.
with a lot of disturbances, I joined this webinar, and I am on AIIMS Madurai duty, sir. And
you are on AIIMS Madurai duty, okay?
Yes, sir.
But Madurai ke liye lunch, this is the perfect time, correct?
Yes, sir. So once again, hearty congratulations and best wishes to you. And please be available as early as you were, even after you become director. Morning only I was discussing with faculties of the physiology of AIIMS Madurai that sir was giving a lot of time to SOPI and us, and after he become director, don't know how he will manage the time and this thing. So I request you, sir, please be available as you were, maybe having a lot of administrative work at AIIMS Patna, but will remain in touch, sir. And and lot of faculties of AIIMS Patna are calling me, and they are waiting for you for your grand welcome. And regarding that, we'll talk on phone. This is the notes. Yes, sir.
Okay,
so
thank you, Satish. Yeah, thank you, Satish.
Yes, sir.
I assure you, in spite of I know my schedule is very hectic ahead. Even tomorrow being Sunday, I have my program. Quite packed program for tomorrow itself. So the programs will be very tight, but I assure you, I will be available to all my colleagues, all my SOPians, and all of you. Maybe I'll not be able to take up your call. You just send a message to me.
Yes, sir.
You'll get the reply within minutes, as I do always, and I'll get back to you all whenever I'm available. And
yes, sir. You are our strong support, sir. And good that you become director, and it will be good for us as well as physiology and for our SOP.
Thank you.
Thank you, sir.
Thank you. Cheers.
Bye.
Yeah. So. They're open.
Yeah, please switch on your videos. We are taking the photo now. Nice. Yeah, so nice.
Done.
Yeah, please switch on your videos now.
Okay, thank you so much, and goodbye for the moment, and we'll meet you again in a new webinar, and maybe from a new venue. Thank you all. Thank you so much.